Okay, guys. Ebony's having a hard time getting hers to connect it all to this, so we'll have her take it later. Um, so I know some of you wanted to see what you did wrong. I can't show you with Ebony in here when she hasn't taken it. So unless Ebony wants to step out for a second and then come back, it's up to you
Step
guys.
out.
All right. Why don't you give us like 5, 10 minutes, okay?
Okay.
All right. All right. I'm just going to pull up the quiz and I'll show you correct answers. I'm not going to pull up your particular one. Let's see here. Okay, so obviously, when we do these tests or quizzes, they all go in a different order, so you may not have the same one first. But for this one, it's saying a client with diabetes receives NPH insulin at 7, and the nurse teaches the client to be alert for signs of hypoglycemia at which times. So the correct answer is between 11 and 4. So, when we learned about those times, you look at the peak time, and that's when you would, say you would want to be more aware of hypoglycemia. So remember, this is intermediate acting insulin. So it's like something like 4 to 10 hours or something for that peak time. So that's why it would be between 11 and 4. All right, so for glipizide, 10 milligrams BID. It's been ordered for an adult client with type 2 diabetes. The nurse would explain to the client that the medication reduces the blood sugar levels. How? So it stimulates insulin release from the pancreas. That's how it works. A client with diabetes receives 10 units of regular insulin at 6 and does not eat breakfast. Around noon, what observation should you expect to see? Well, if they didn't eat breakfast, they're probably going to have a low blood sugar, right? So, signs of hypoglycemia, so it would be diaphoresis. All of these other things are not anything to do with hypoglycemia, these are to do with hyperglycemia. Number 4 says what would be important for the nurse to include in the teaching plan for a client who's taking insulin. Um, when mixing insulins, regular insulin should be drawn up into the syringe first. So when you're doing that whole thing, you always draw up air first, and you put the air in the intermediate acting one first, and then into the clear last. But then when you're drawing up, you always draw up clear before cloudy. A client with type 1 diabetes calls a nurse about nausea, and not feeling well. What would be important for the nurse to tell the client? So all this question is getting at is this person sick? So you need to tell them what to do for sick day rules, right? So take your insulin dose, replace food and fruit, food with fruit juices if you can't keep food down, and monitor your blood glucose. That's what you would tell them. And then this DKA question. The nurse is caring for a client in DKA. In order to order exists for insulin to be added to the current infusing IV. What type of insulin will you use? It's always going to be regular insulin, never anything else. Number 7 is talking about a hemoglobin A1C. This one, you don't have to fast or anything like that for it. You can come to the clinic at your earliest convenience to have the blood drawn. So there's no need to fast for that because, again, this is telling how your blood sugar has been for the last so many months. And so there's no need to fast for it. Number 8, the nurse is assessing an 80-year-old client with type 2 diabetes. So remember when we were talking about, hey, how you have to pick out the differences between DKA and HHNS because they're very similar. So remember we said DKA is more type 1 diabetics. Type 2 diabetics kind of goes with the HHNS, right? The other thing was with HHNS, these guys usually are sick in some way. Something sets them off into going into this episode. and they have a lot of neuro symptoms. So one of the things that's a neuro symptom in this question is the lethargy. So the rest of the question says the assessment findings include rapid deep respirations at a rate of 36 breaths per minute, which you could see that with both. But then the clue here is that lethargy. Lethargy and tachycardia are present. What would the symptoms indicate? So you're going to pick the HHNS or HHS, whichever one you want to call it. All right, number 9 says a nurse is teaching a mother of a child with diabetes how to recognize the signs and symptoms of hypoglycemia. What are some signs and symptoms that she should discuss? It's going to be behavior changes, increased heart rate, sweating, and tremors. And there's a ton of them you could list here, but those are the ones you would pick. And then the last one's about Actos, which is another oral diabetes med. So it says you're caring for someone who's prescribed Actos. After 6 months of therapy, the client reports that his urine has become darker since starting the medication. What action should the nurse take? You're going to review his liver function study results, because when you take Actos, it can affect that, make your liver function studies abnormal. So that's all this was, you guys.
Well, I'm just glad it's only 10 points.
Yeah. Do you understand stuff that you did wrong? Do you need me to explain anything
No,
better?
you explained it very well. I'm happy now.
Okay. Everyone else feel the same or no?
Can you just repeat? I got it right, but I don't know. It always screws me up because I forget. Go over the insulin drop again.
For,
Aaron,
for when you do 2 in the same syringe?
yes.
Okay. So you always draw up air first, right? So
Yeah.
for instance, if I had an order that said, I want to draw up, or I want to give 10 units of regular and 5 of NPH. So I'm going to draw up my 5 units of air first, because this is the intermediate acting insulin. So I'm going to draw up my 5 units of air. I'm going to squirt it in my bottle. Then I'm going to take my syringe out of that. And then I'm going to draw up my 10 units, my 10 units of air for my regular. And then I'm going to squirt that in my bottle. Instead of taking my syringe out at that point, I'm going to just flip it back over after I've put my air in there. And now I'm going to actually draw up my 10 units of R. Then I'm going to take my syringe out, put that down, go back to the intermediate, and then I'm going to turn that over and draw up my 5 units of N. So you just think you do the intermediate for the air first and then the regular, and then it's the opposite for actually drawing them up.
Okay. I mean, I got it, but it was just I had to sit there for a second. I was thinking that lady RN, she was like, "Remember RN," but I'm like,
Yeah.
"Who? Is it the air?" Or... Okay, thanks.
Yeah.
That clarifies it.
Okay. All right. We good? Okay. So that's that. So let's get out of that junk. All right. So for those of you who had a presentation today, what's your feeling? Do you want to get that over with, or do you want me to go over a little bit of content and then do one, and then go over a little bit of content, do another one? What do you want to do?
I would like you to go over a little bit of content. I think. Do we have to have our cameras on if we're sharing our screen?
Well, I have to put on the bottom here that everyone can share their screen, so you're able to, but then, you're just sharing your PowerPoint. So we just need to see your PowerPoint, and we need to hear you talking about it. That's all.
Yeah, that's it. We don't have to do the camera then.
Yeah.
Okay.
Okay.
Thank you.
What about anyone else who is going today? Are you okay with that, or?
I know I go today. I'm fine with that.
Okay.
I'm fine with that also.
Okay. Well, let's try it. Let's see how it goes here. All right, so this, if you took a look at this PowerPoint earlier, you can see it's huge, right? There's just a ton of information to go over. Every time I teach this, everyone's like, oh my gosh, my head wants to explode afterwards. So maybe this will actually work out better, if we just do a little bit at a time. So one thing I do want to tell you is that, let me see if I can share this real fast. Here we go. One thing I do want to tell you is sometimes it's helpful to do your notes in a certain way for this topic especially. So as we go through these different disorders, you'll see that they're opposites of each other. So the thing is, like, if I'm, like, say here's my piece of paper and I draw a line down the middle, and maybe on the one side I have hypothyroidism, and on the other side I have hyperthyroidism. And then I'm going to write things on either side of this line about these things so I can see how they're different and how they're similar. So that might be some way that you might want to do your notes. Just see how it goes as we go here. So the first stuff I'm going to talk about is going to be diabetes insipidus and SIADH. So we'll take those two things first, and then we'll take a little break and have a presentation. Okay, so this first slide here, this just shows you where some of these things are coming from that we're talking about. When we talk about endocrine disorders, it's all about hormones. And these hormones come from different areas in our body, and usually it's either we have too much of one or not enough of one. And so this just kind of gives you an idea of where some of these things are coming from. So like a lot of it comes from your brain up here in the hypothalamus or the pituitary gland or whatever. So you can see kind of where those things are located at. And then when we talk about the thyroid and the parathyroid, right here in your neck area, right? And then when we talk about the adrenal glands, some of the disorders having to do with that, those are just right here on top of your kidneys. So there's two of those. So those are the main ones that we talk about. So I just want to kind of give you an idea of where they're located. Okay, so as we go through these disorders, the things that I really want you to pay attention to is what's the hormone that we're talking about? Is it too low or too high in that disorder? I want you to know possible causes of the disorder. I want you to know what you would see in that person if they had this, so signs and symptoms. Then I would want you to be aware of some possible lab work that you might see associated with this. And then how would we treat it? Those are the big things I want you to pay attention to. Okay, so for the first one, diabetes insipidus. Do not get confused that this is another type of diabetes. It is not that. So even though this is the name of it, that's not why it's called that. So what's happening here, the hormone that we're looking at is antidiuretic hormone, ADH. So with this disorder, diabetes insipidus, you're going to have not enough of this hormone. So let me kind of tell you about what this hormone does a little bit. So this hormone controls our fluid removal rate in our body. So like our body kind of senses when we have too much fluid on board, so it would kick in with this ADH to kind of help take care of that. So it regulates fluid by producing ADH in the hypothalamus. So remember that picture I just showed you. So our hypothalamus is right here. Okay, so anyway, the pituitary gland stores the ADH. So it's produced in the hypothalamus, and then it gets stored in the pituitary gland, which is also up there in the brain. And then it releases it into the bloodstream when the body has a low level of fluid. ADH signals the kidneys to absorb less fluid from the bloodstream, and this results in less urine. When the body has extra fluid, the pituitary gland releases smaller amounts of ADH or sometimes none, so the kidneys would remove more fluid from the bloodstream and produce more urine. So that's kind of how this works. So it just depends on how much fluid you have in your body. If it senses that you don't have enough, then it's going to signal this ADH to produce more. If it says that you have too much, it's going to make it produce less. So with this particular disorder, it's not real common. It's very rare to see this. So some of the things that would be possible causes would be things like maybe someone had a head trauma or brain trauma. Something happened to them where they got some kind of brain injury. That could cause this. If they had a tumor in their brain, that could cause it. Sometimes your kidneys just aren't receptive to ADH, so they just don't work in accordance with that, and so you could get something like this. Again, if you had damage to the hypothalamus or the pituitary gland themselves, that could cause it. And there's a couple other reasons. So certain drugs could cause this to happen, certain drugs that you take. And then also, you could get a gestational version of this. So you know how when we talked about gestational diabetes, and we said that it had to do with your placenta, and the placenta is producing all these crazy hormones and it's causing you to seem like you're diabetic when you really aren't. Well, with this, you could have gestational diabetes insipidus, and it happens when your placenta produces too much of a hormone called vasopressinase. And that hormone actually breaks down ADH, so you're not going to have enough ADH. Okay, something else I want you to write down real quick about this. And chances are you're probably not going to have a question that's this specific about it, but I'm just telling you FYI. So there's different types of this disorder. So you can have what they call a central diabetes insipidus. You can have a nephrogenic type of this. You can have a dipsogenic type of this. And then also that gestational form that we just talked about. So those are the different types. So if you have central diabetes insipidus, this means that you have damage to your hypothalamus or your pituitary gland. That's the cause of why you have it. If you have nephrogenic diabetes insipidus, this means that it's a problem with your kidneys. So your kidneys aren't responding to that ADH very well. And the dipsogenic is a defect in the thirst mechanism located in the hypothalamus. So like you just don't know to drink enough. And then the gestational, again, is because of that hormone that's produced by the placenta, that vasopressinase, that breaks down ADH. So those are the causes of why you would have each one of those types. Are you with me so far?
Yeah.
Okay. All right, so the next thing here is the signs and symptoms. So this is really important for you to kind of get this down to understand what's happening here. So again, we don't have enough ADH in our body, so that's why we have this disorder. So when we are looking at signs and symptoms then, it's kind of crazy. We are producing a ton of urine with this disorder. So you could see people put out like 4 to 30 liters of urine a day. Can you even imagine putting out 30 liters of urine yourself a day? You would be constantly on the toilet, you know? So, of course, this person is going to be very thirsty all the time. So, polydipsia is going to be part of this because they're so dehydrated from putting out all of that urine. So, you will see this person drink, drink, drink all the time. So, this might be a person that you're taking care of at the hospital who is like, oh, I need more in my water pitcher. And you're like, I just filled that. Well, no, I drank it all. I need more. So they go through tons of fluid, like according to this, 2 to 20 liters a day. So they just can't seem to get their thirst quenched. Then, of course, they have nocturia because they're putting out so much urine. So they're up in the middle of the night going to the bathroom constantly. They're very fatigued because they're so dehydrated. And then just think kind of to the extreme. So if someone is super dehydrated because they're putting out all this urine, they can't get enough to drink, then they're going to look a certain way. So what's our skin turgor going to be like?
Wouldn't it be tenting?
Yes. So you have a loss of skin turgor. So yes, you would see that tenting with this. What would your mucous membranes look like?
They'd probably be like hypoactive, right? Or hyperactive, right?
Well, so
Like-
we're dehydrated, so our mucous membranes would
no,
be
I was thinking excessive fluid. No, they'd be dry.
they'd be dry, definitely. And then some other things I have written down here, you could see someone with tachycardia. You could see really weak peripheral pulses and decreased cognition. So sometimes this person might be a little bit confused at this point. They can have a low blood pressure, and then they can also have really sunken in eyes. Like if you've ever looked at pictures of people who, I don't know, they were in concentration camps or something and they're super malnourished and they haven't had enough to drink and stuff, they look like that. They have sunken in eyes, right? So that's kind of what this person would be like. So your big things to remember then with these signs and symptoms are that even though you're not producing enough ADH, you're putting out a ton of urine, so much that you're dehydrating yourself. And so just think of like those symptoms of dehydration, and that's what you're going to have with this. So when we think about labs then, if you think about your blood work, so your blood work is going to be more concentrated because you are putting out so much urine. You don't have a whole lot of fluid like floating around in your blood. It's like a lot less because you're putting out so much. So anything that's floating around in your bloodstream, like whether it's sodium, potassium, whatever, any kind of solutes, that's going to be increased in this. So just think, I don't have enough fluid, so anything else that would be in there would be more so. Like picture, if you had a glass of Kool-Aid or something. Like this is milk here, but so look at my glass of milk here. If this was water and I put in some powder, like I was going to make a glass of Kool-Aid or something, if I don't have enough fluid in there, what happens to my Kool-Aid?
It'd be really concentrated.
Definitely. Did you ever do that? You make something and it's like way too strong because you don't have enough water in there, right? So same thing here. It's just like that. If you don't have enough fluid, whatever you have in there is going to be more concentrated. Does that make sense? Yes, no?
I mean, yeah, the Kool-Aid analogy is perfect.
Okay. I wish I actually had some so I could show you, but all right. So anyway, that's what's going on with your blood. So then if you look at urine, then urine's going to be really dilute. You're putting out such a huge amount of urine that you're not going to have hardly anything in it. It's almost going to look like water. So all of the things that might be floating in your urine, such as potassium, sodium, whatever, that's going to be really decreased because we have more fluid than we have solutes now. So all of your urine tests would be really decreased. So pH, osmolality, all of those things. So blood would be concentrated, urine would be dilute. Okay, so believe it or not, get on my right page here. To figure out if someone has this, if they're suspecting it, they have something called a water deprivation test that they do, which seems kind of inhumane in a way. So they actually will withhold fluids and actually induce dehydration in someone to see if this is what's going on. So the test is positive if your kidneys are unable to concentrate urine despite increased plasma osmolarity. So during the test, you as the nurse would be monitoring their vitals frequently. You would be doing urine tests with them to see, like, measuring the specific gravity of their urine. And you also check their weight. And so this could be going on for hours, this test. And then you're going to discontinue it and rehydrate the patient for a loss of more than 2 kilograms of body weight, because that's kind of a lot. So that's one of the tests that they could do for this. And then there's another one, a vasopressin test. This is a subcutaneous injection of vasopressin. And vasopressin is kind of ADH. That's kind of what, it's like a synthetic version of that. So it's going to produce urine output with an increased specific gravity if the patient has central diabetes insipidus. Remember, we just talked about that a few minutes ago. That central meant that it was caused by a defect to the hypothalamus or pituitary gland. So this test would tell you which type they had. So it kind of helps to differentiate between the kinds, the types, if that makes sense. Okay, so then with treatment. So for someone who has this, there is an actual medication called desmopressin that you could give. And this can either be taken by mouth or IV, or there is even a nasal version of it that you can do a nasal spray. This should result in an increased water absorption from the kidneys and decreased urine output. So again, you don't have enough ADH, so this is kind of like a synthetic version of it in a way, so that you're getting it in some way to decrease some of your symptoms. So when you're taking that, how do you think you would know that it's working well? How do you know that it's being effective?
Maybe they're not peeing as much.
Yes, that's going to be a big time thing that you're looking for. Because again, remember we said they're putting out liters and liters of urine. So if that cuts down quite a bit, you know that it's working. So that's good. Okay, other things that we're going to watch for. Again, you want to monitor for the effects of water intoxication as well. Because remember, this person is constantly thirsty and they're constantly trying to drink. You can have water intoxication. So if you have this, you'll get things like headache, confusion, increased somnolence. So you definitely want to watch for that. So you kind of have to limit how much they drink so they don't overdo it. This person is actually going to get IV therapy. And it seems funny because, they're putting out so much urine and stuff. Why would you make it worse and give them IV fluids? But they're so dehydrated because of all of that. You need to replace that somehow. So the IV fluid would be given, and it has to match how much they're putting out. So like if I'm putting out a ton of liters of urine, I have to kind of match that with how much I'm giving in IV fluids. This person is going to be at increased risk for falls. So you want to monitor their safety during this as well. So they're always going to be an assist up to the bathroom, because think about it, if I have low blood pressure and all of these things, I could, pass out real easily when I get up. You can have dizziness and lightheadedness and all of that in association with dehydration. So another thing we're going to do, we're going to restrict foods that would have any kind of diuretic effect. Things like caffeine, which that's hard for a lot of people because a lot of people like caffeine, right? I don't know if I have it on another slide. Oh yeah, I think I have it on the next one. Okay, so as far as patient education with this, the patient has to weigh themselves every day while they take this, which they're going to take this for the rest of their lives because you can't fix this. So they have to weigh themselves every day at the same time, notify their provider if their weight gain is 2 pounds in 24 hours, because that's a problem, and then eat high fiber things, and then wear a Medic Alert bracelet. That Medic Alert bracelet is going to say that you have this disorder so people know in the future if you run into issues. Other stuff, you want to monitor for this dehydration and make sure it's not going to get worse. So if they start getting confused, that's saying that they're not doing too well. So you need to really start treating them more. Teach how to give the intranasal dose correctly if that's what's ordered. A lot of people don't understand how to do nasal sprays the right way. What is the right way to give a nasal spray, you guys? What would you say to someone if you're trying to teach it? No one knows?
You make sure they get everything out of their nose first.
Okay.
And then I would do like a test to make sure that it's actually fun, like prime it almost, like it's actually working.
Yeah.
And then squirt it up your nose and inhale, squirt it up the other nostril and inhale.
Don't you occlude one nostril when you're doing the other one?
I'm going to go with yes because you're saying it. But
Yeah, you're supposed to occlude one nostril. And then which way are you supposed to point the nasal spray? Are you supposed to point it towards the middle part of your nose or a little bit out?
I don't know that answer.
Okay, that's okay. So you actually are supposed to point it out a little bit. They don't want you to point it towards your nasal septum because you can actually cause problems if you keep doing it that way. I used to work for an ear, nose, and throat doctor, and we would see people all the time who were addicted to nasal sprays, and they would spray their nose constantly, and they would end up getting like a hole in that nasal septum, so it would be connected from both sides. It was crazy. So you definitely want to kind of point it towards the outer portion of your nose. It doesn't mean that you can't like put it up your nose and point it a little bit. You can't just spray. You got to point it a certain way. Okay. The other stuff, this is something they have to stay on lifelong. They can't just take it for a few weeks and say, oh, I'm done. This is a constant problem with them for the rest of their life. So they have to take this so that they don't have these issues. And then the other thing, it says avoid consumption of alcohol because it's very dehydrating and they're already super dehydrated. So couple other things, we said we want to keep really good intake and output on this person because, we already know they're having issues with their output. So we want to really keep a close eye on that. We do these weights every day for sure. Again, we do the safety checks and really, help them get back and forth to the bathroom, make sure they're not falling or anything. We're monitoring their electrolytes. We're probably going to give them electrolyte replacement because they're probably going to be, out of whack with some of that. And then IV fluids for sure we're doing. So have you guys heard of any types of foods other than caffeine that are really high? They have like diuretic effects to them, like foods that you eat?
It's asparagus.
Asparagus does? Okay.
It makes the pea smell at least.
Yeah. What else?
I only thought it was coffee. I didn't know there were others.
Yeah, so it's actually kind of fruits. So watermelon is one, and also berries, which I wasn't really sure about the berries. I could kind of see the watermelon a little bit, but okay, one more thing I want to tell you about this before we go on. So again, with this treatment, remember you're taking that medication and you're taking it for the rest of your life. So I want you to write down a couple of different names for this medication so you don't get confused if you see one or the other. So again, we said it's called desmopressin, which I have on the one slide already, but sometimes you'll see it called DDAVP. So it's just an abbreviation. So 2 D's, an A, a V, and a P. So just a little bit about this medication. So again, it can be given a bunch of different ways. It's basically just a man-made hormone used to help control urination and thirst in someone with diabetes insipidus. So what it does is it causes an increase in water absorption from the kidneys. And so then it would decrease your urine output. So some of the things you might see as possible side effects of this would be things like headache, nausea, upset stomach, diarrhea, flushing of the face. So nothing too horrible, but a little bit not so fun, you know. Okay, someone tell me what you just learned about diabetes insipidus.
Too much.
What did you retain from what I just said about diabetes insipidus?
The patient is always thirsty but appears to be dehydrated upon assessment.
Okay. What else, Brandy? What does their labs look like?
The blood is really concentrated.
Okay, and then what would the
and,
urine?
The urine is more diluted because of the decrease in the pH and osmolarities.
Well, the urine is more dilute because they're putting out so much of it. They have more fluid there than they do solids.
Okay.
Okay.
All right.
All right, Ashley, what do you think? What is something that stuck with you about diabetes insipidus?
I already said about the urine, right?
Yeah. So what would be some things that we would do for this? How do we treat this?
Medication, but I don't know what the medication is.
Okay, so it's that desmopressin. And remember, desmopressin is just a synthetic version of ADH.
Okay.
All right, Brandon. So what does antidiuretic hormone do for you?
It helps us to process urine to go to our it like helps us to pull all of our fluids like down to our kidneys.
Okay. So in diabetes insipidus, do we have too much or too little of it?
Too little.
Too little, yes. Okay. All right, so we are going to move on now to SIADH because it's the opposite of this. So it's kind of neat in a way because as we're talking about these things, you'll see that if you know one, if you have one of these down, you'll know the other because everything's opposite. So it's not too bad. Okay, so SIADH. So what this stands for is Syndrome of Inappropriate Antidiuretic Hormone. So in this one, instead of having too little of ADH, now we have too much of it. So we're overproducing it. And remember we said with the other one we just talked about, with diabetes insipidus, that person is producing a ton of urine. So what do you think this person would be doing in SIADH?
Very little.
Yeah, they're not going to be putting out as much. So with this one, here, let me just look at my notes a little bit here. So there's some different causes for this one that I want you to kind of pay attention to, and especially in our chapter in the book, I know it mentions this specifically. So again, you could have damage to the hypothalamus or the pituitary gland just like you could with diabetes insipidus, and it could maybe be causing this. Or maybe you have lung cancer. Do you believe that? Lung cancer can cause this. In infection, like meningitis, think about someone who has like, an infection of their meninges in their brain, that could cause this. If you've had something like a stroke or Guillain-Barré syndrome, that could cause this. There's a ton of different things. So you just kind of have to rule out some things to figure out kind of what it might be. So if I had someone with this and I was a physician trying to figure it out, I might, maybe I would send them for a CAT scan or something to see if they had some kind of issue with their brain, or maybe I'd look at their medications to see what they were on, to see if maybe it was one of the medications, because in here, like this is saying certain medications can cause this. So specifically for SIADH, some of the antidepressants like tricyclics and SSRIs, they can cause it. Chemotherapy agents, fluoroquinolone antibiotics, there's a few different things. So it could be something simple like that maybe you could fix. All right, so again, what ADH does is it helps control our fluid in our body. And so we always have like these mechanisms inside our body to where our body tries to help us out. If it notices that we have too much fluid or too little fluid, it tries to kick in and help us with that. So with this one, now I'm going to have too much fluid on board. So remember with the other one, we didn't have enough fluid on board. We had too little. And this was because we were putting out so much of it, right? Well, now we aren't putting out so much of it, we're holding on to it. So this person is going to have some different signs and symptoms. So think back to when we talked about fluid volume overload. That's kind of what this person is going to be like. So you're going to see things like weight gain. You might see a high blood pressure with this one. You could see a fast heart rate. You could see confusion, anorexia, seizures. You're going to probably have a low urine output and really concentrated urine now. When you look at this slide, I'm sure I have more than what I just said here. There's probably more that I listed here that I didn't just say, but you guys can read through those. But yeah, so anyone who has too much fluid on board, think about some of the signs and symptoms that you would see with fluid volume overload. What does your jugular vein look like with that?
Distended.
Yeah, it's going to be distended. What else would you see? You'd probably see edema. What do you think their yeah. What do you think their lungs would sound like?
With crackles.
Yeah, probably crackles for sure. So this person's just going to have too much fluid going on. So now we have to do something to help with that. So this will go through labs first. So now our labs are going to be opposite, right? So now our urine is going to be really concentrated because we're not putting out very much urine. And then our blood is going to be more dilute because we have too much fluid on board. When we have a lot of fluid in our vessels outside of our cells, that's a problem, right? So that's going to mean that we have like decreased serum sodium, decreased osmolarity, all of those types of things. So your blood is dilute, your urine is concentrated with this one. So then again, just think like some of the things you would do for someone who had fluid volume overload. We're probably going to do a fluid restriction, right? So with this one, it can be pretty extreme, 500 to 1,000 milliliters a day. And that's probably going to be one of the first things that you do. Then say you have to flush something that they have going on, like maybe they have an NG tube or a PEG tube or something, and you have to flush it every so often. They want you to not flush it with sodium chloride. Or excuse me, with water. They want to do sodium chloride instead of water because you have too much fluid on board. So yeah, you're going to be really particular on what you do. You're going to weigh this person every day, just like you would for diabetes insipidus. And then you want to monitor for indications of fluid volume overload. So where it could go to the extreme, to like where you would go into heart failure, or you would have pulmonary edema or something like that. So we don't want it to get to that level. Some of the other things that we're going to do. I guess I'll come back to that. We are going to probably give them loop diuretics because remember we, like Lasix or something. This is going to help get rid of some of that fluid. So it's going to make the kidneys excrete some of that water. And then we're going to give them a vasopressin antagonist. So remember with diabetes insipidus, we did desmopressin, which was a synthetic form of vasopressin. So now we want to give something that's going to be an antagonist for that. We don't want it to work like we did with that, So this medicine is going to promote water excretion without causing sodium losses because we already have a problem with that. Now, think back to when we talked about the different types of IV fluids. So see why I talked about that forever ago, because it keeps coming back in different other things that we talk about. So isotonic, hypotonic, hypertonic, right? So in this, since we have too much fluid outside of our cells, what does our cell look like? Our cell's going to be really shrunk up, right? And so to give them something to fix that, we're going to give, or I'm saying this wrong, I'm sorry. So again, we have too much fluid outside of the cell. So we want to suck some of that into the cell, right? So if you give a hypertonic fluid, that's going to elevate the sodium level enough to help with that neurologic compromise. And we're going to monitor their fluid overload and their heart failure, monitor for all of those things, right? So one other thing I want you to write down, find it here. So that medicine that I was talking about, the vasopressin antagonist, a specific name for that, which I can't pronounce it very good, but it's demeclocycline, something like that. So I'll spell it for you. It's DEMECLOCYCLINE. So again, this is like an antidiuretic hormone inhibitor. So this medication is a derivative of tetracycline. And what it's going to do is it's going to inhibit the action of ADH on your renal tubules, and it's going to allow for diuresis of water. So it's going to make you be able to put out more fluid. All right, other things like as far as interventions that we would do, again, we already talked about the fluid restriction, the daily weights, the INOs. That's like similar to what we do with everything else. We talked about loop diuretics, but what's something that you should worry about when you give someone Lasix? What other like lab would you be monitoring?
Potassium.
Potassium, right? Because it always goes hand in hand. Your potassium would probably get out of whack and probably too low. So anytime we give Lasix, we always want to make sure their potassium's within normal limits. So what's our normal level of potassium?
3.5 to 5?
Yes,
No.
good job. You're right.
Really?
You're right.
Oh, okay.
So anyway, if you were going to give someone Lasix and say they were at 3.4, what would you do?
Hold the Lasix.
Well, you want to call your physician and you want to say, hey, I noticed that this person's at 3.4 for their potassium. Can I get a potassium replacement for them? And they'd be like, sure, thanks for letting me know. So yes, you're right. You would hold the dose until you take care of that. But I just want you guys to understand that you shouldn't just hold something without talking to the physician about it. So a lot of people do that, and it ends up causing a problem. Like, I remember when I used to work, they used to, especially with like diabetics, like say you go to give someone insulin and their blood sugar is low or something. So of course you're not going to give it, you know? But if it's a continued issue and it's happening every day and no one's saying anything about it, then how is the physician going to know? You know, maybe he just needs to change something around so they don't keep having that problem, you know? So that's why I just want to make sure you're aware that you need to be constantly talking to the physician about some of these things, okay? All right, so let's see what we remember about this. Okay, Olivia Mooney, what stands out to you about SIADH?
Could you repeat that? Sorry.
What do you remember about SIADH after we just talked about it? What do you remember?
It's the opposite. So you're going to be holding everything in. You're not going to be, urinating like crazy like the other one. And I'll just lead with that, I guess.
Okay, that's all right. All right, how about Olivia Cessna? Are you still here? I can't see everyone on my screen.
Yeah, I'm here.
Okay, what do we do for SIADH? What kind of things do we treat it with?
You could give the loop diuretic, a fluid restriction, the vasopressin. I don't know how to pronounce it, but you could give them that. If you're you have to like flush, you would use the sodium chloride and not water.
Okay. And then, believe it or not, there's times where we actually give, and I don't know if I said this or not, hypertonic IV solution. So this is like that 3% saline. So this is going to remove fluid from the cell and take it back into the vascular system where they have too much fluid, but it helps to get some of that urinated out. So you wouldn't just do that by itself. You would give that in addition to your ADH inhibitor, you know, but it just kind of helps get some of that stuff back out into the vascular system so you can urinate it out. Let's see, who else is in here? Samantha Williams, are you still here? No? How about Ebony? Ebony, what do our labs look like with SIADH?
Miss Silk, I'm not even gonna lie. I'm still trying to get into this land school, so I'm irritated right now. So I haven't been really listening.
Don't worry
I've been
about
listening.
Don't worry about land school. We'll mess with that later.
Okay.
Just try and concentrate on what we're talking about. So with
Okay.
SIADH, I want to know, what do you think our labs would look like? What would the urine look like with SIADH? Would it be concentrated or dilute?
Would it concentrate?
Yes, it's going to be concentrated because we're not putting out as much, right?
Mhm.
So what would your blood look like then?
Like the levels will be elevated.
So
Is that what
your blood would be dilute in this.
Oh, okay.
Because we have too much fluid going on in our vessels outside of our cells. Okay, so our blood is dilute, our urine would be concentrated.
Okay.
Okay.
Mhm.
All right. How about Jen Hollis? Jen Hollis, what's going on with ADH in SIADH?
It's high.
Yes, we have too much. So, let's see if I can find another thing. What would be a cause of SIADH? Anyone can answer.
Tumors.
Okay. What else?
Lung cancer.
Yes, and I really want you guys to remember that lung cancer because people forget that all the time. And when you do your reading in the book, I can't remember what kind of lung cancer it is. I want to say it's small cell, but they're specific about it in the book, like what kind causes it. So make sure you look at that. Okay. So again, if you know one of these, you should be able to kind of know the other because they're just opposite with everything. So your labs will look opposite. What's going on with the hormone will look opposite. Your signs and symptoms will look opposite. And then you just have to think, okay, what's going on? How would I treat that? You know? All right, so let's stop here for a minute. All right, who wants to do their presentation first?
I can go.
You want to go? Okay. Let me see if I can allow everyone to share their thing. Let me find where that's at in here. I always forget where that's at. There we go. Took me a minute. Okay, see if you can share your screen now.
Okay. Can you see it now?
Yeah, now I can.
Okay. All right, cool. Can you hear me okay?
Yep.
Okay. Okay, so my presentation is on urinary incontinence. I'm gonna switch this down. What is urinary incontinence? Urinary incontinence is defined as the inability to control the loss of urine from the bladder. It is reported that about 25 million adults in the United States suffer from urinary incontinence. Many incidences of urinary incontinence goes unreported due to embarrassment. So pathophysiology. First, I'm going to go over kind of like what normally happens in the body, and then I'll kind of go over like the causes. So in normal micturition process involves a balance between the detrusor muscle and the urethral closing. Urethral pressure is generally higher than bladder pressure, which allows urine to stay in the bladder and results in urine continence. The stretch receptors in the bladder increase their firing rate when the bladder fills. This sends a signal to the brain that informs the body that it needs to urinate. During urination, the urethra pressure decreases and the bladder pressure increases, causing the shift of fluids and the release of urine through the urethra. Change in pressure and ability to control the micturition muscle can lead to incontinence. So some causes that impede natural urination elimination would be neurogenic disorders such as stroke, dementia, diabetes, multiple sclerosis, Parkinson's disease, spinal cord dysfunction, an acute injury or degenerative disease. Non-neurogenic disorders would include bashful bladder, so that's like being shy, like you can't really go in public areas, overactive bladder, after general surgery and after prostate surgeries. Types of urinary incontinence. So stress incontinence is due to increase in intra-abdominal pressure from changing positions, sneezing, or coughing. Urge incontinence due to a strong feeling to urinate without being able to hold it. It kind of comes on all of a sudden. Functional incontinence due to physical or cognitive deficits, so like such as like dementia or Alzheimer's, like they can't really tell you that they have to go because they have cognitive deficits. And then functional or physical would be like, you know, you're bound to a wheelchair and you just can't make it because, you know, you have physical deficits. Iatrogenic incontinence would be due to extrinsic medical factors, oftentimes like side effects of medications and such like that, like diuretics and stuff that kind of causes that urge to go all the time. Mixed incontinence would be associated with urge and stress incontinence. So that's like urgency with exertion, effort, sneezing, or coughing. So you'd be like lifting something and then you'd have to hurry up and stop because, oop, I gotta go right now. Overflow incontinence would be due to a weak bladder muscle or a blockage inhibiting the release of urine from the bladder. So that's often seen with like BPH, you know, benign prostatic hyperplasia. Risk factors for urinary incontinence. So risk factors would include age, toilet availability or help, you know, availability in patients that are bound to like wheelchairs and such like that. Cognitive disturbances, diabetes, surgery, exercise, immobility, urethral relaxation, or trauma due to scarring. A lot of times like there's scarring due to like frequent UTIs and such like that. Or like if you're a self-catheter, a lot of times like males, they'll end up causing a little bit of damage and might cause some scarring. Certain medications, menopause, because the low estrogen causes like a decrease in the elasticity of the urethra. Morbid obesity, pelvic muscle weakness, pregnancy, and stroke. Signs and symptoms of bladder control issues would include leaking urine during any normal activity such as exercise, coughing, or bending, suddenly feeling a strong urge to urinate immediately, leaking of urine with no urge to urinate, so they just don't even feel it, they're just leaking and they don't even know they have to go. Unable to reach the toilet in time to urinate, so it's just like with that urge incontinence, like you just have to go right now and then you end up being incontinent because you haven't made it in time. Nocturia with incontinence through the night. So, diagnosis. Patients with urinary incontinence should be seen by a urologist to help properly diagnose them. History and physical examinations of the patient will focus on medical procedures, medical conditions, medications, illnesses, use of drugs, and urinary patterns to help identify the cause and type of incontinence. Residual urine and bladder capacity will be tested using a bladder scanner to look for evidence of bladder muscle malfunction. Other tests performed include stress tests. So this is where like the doctor will kind of have you like relax, and then he'll have you cough several times just to kind of increase that intra-abdominal pressure to see if you lose any urine during that time. Urinalysis, they'd be testing your urine to see if there's any infection that's causing this incontinence, stones, or like any additional causes. Blood tests, they'd be checking for substances that could be contributing to the incontinence. Ultrasound would be looking at the structure of kidneys, ureters, bladder, and urethra for deficits. Yeah. Cystoscopy is a thin scope inserted into the urethra to visualize the urethra and bladder. And urodynamics is the use of two catheters. One is inserted into the urethra, and that's to measure the bladder pressure, but it also is used to fill the bladder during this test. And the other into the vagina or anus, depending on gender, to measure the abdominal pressure, to measure the pressure of the bladder and adequacy of bladder filling. So treatment for urinary incontinence. Treatment depends on type of incontinence. Treatment can be behavioral, pharmacological, or surgical. Behavioral therapy is the first choice to treat urinary incontinence, to avoid adverse effects associated with pharmacological and surgical management. Pelvic floor exercises or Kegel exercises help to strengthen the muscles and help treat stress, urge, and mixed incontinence. Additional behavioral interventions include voiding logs, so like diaries, like how often you're going, you know, if it feels like you're going enough. Biofeedback, scheduled training. Usually they try to do that every 2 hours and then they'll expand it. And physical therapy. Pharmacological therapy works best with behavioral interventions. So some of the meds here, kind of harder to pronounce, so I'm going to save you guys the butchering for the first line. But anticholinergic agents inhibit bladder contractions, and that helps to treat urge incontinence. Tricyclic, antidepressants, amitriptyline decreases bladder contractions and increases bladder neck resistance. And Sudafed, believe it or not, works on alpha adrenergic receptors that results in urinary retention, and that helps treat stress incontinence. But you have to really be careful if the patient has BPH when they're on this medication or hypertension, since it causes that urinary retention. And with, you know, those two things like hypertension, they're already in fluid overload generally, and BPH, you know, they're already retaining the fluid also. Treatment continued would be surgical management. Last resort for treatment depends on gender and type of incontinence. Most procedures are aimed at stabilizing or lifting the urethra or the bladder. Anterior vaginal repair, retropubic suspension, or needle suspension, which all help to reposition the urethra in women with stress incontinence. Periurethral bulking is artificial collagen added to the walls of the urethra to increase closing pressure. That's semi-permanent. It only lasts about 12 to 24 months. But when I was reading up on it, it said that it's not like, you know, any of the other surgeries, because it's less invasive. Well, it also is invasive, but they don't have any restrictions after it. You know, they can just go about their day. They don't have to, you know, but again, it only lasts 24 months. But they don't have the side effects of regular surgery. Artificial urinary sphincter. There's two types, periurethral cuff and a cuff inflation pump. So that kind of helps them, you know, hold on to their urine a little bit. Transurethral resection for prosthetic enlargement. Treat men with stress and overflow incontinence due to like BPH. Oh, and then hold on, sorry. And then this little picture over here, it kind of just tells you, like, because again, like on the first slide, I said how a lot of people don't report that they have incontinence because it's kind of embarrassing. So here's some strategies that a lot of people try to use instead of actually seeking help. So it says 59% of people use pads and protective garments. 38% of people try to do pelvic floor exercises. 16% of people just try to limit their fluid intake, and 15% modify their wardrobe to hide their accidents, which obviously is no form of treatment at all. Okay, nursing diagnosis with interventions. So the first one I chose was impaired urinary elimination, obviously. And so like a couple interventions would be initiate bladder training programs by instructing the patient to void or attempt to every 2 hours. Patients with catheters, tubing should be clamped for specific times and unclamped during specific times because you're trying to retrain that bladder to know when it needs to go. Instruct the patient to keep a voiding diary every day to identify the need to lengthen the interval between voiding or attempts with bladder training programs. So that kind of helps you monitor like the effectiveness of like how the training program is going. Risk for impaired skin integrity. Interventions would include assess patient's perineal skin every 4 hours for signs and symptoms of skin irritation or breakdown related to urinary incontinence. I mean, you don't technically have to do it every 4 hours. It's pretty much you're kind of assessing it every time they're either bathing or every time there's an incontinent episode. I just kind of put that in there to kind of make it seem more like an intervention. Provide perineal care every shift and or after every incontinent episode using non-irritating soaps with warm water and always pat dry afterwards. Body image disturbance was the last one I chose. Interventions would include provide positive feedback with an optimistic attitude during patient interactions, kind of just to let them know that you're not thinking ill of them, you know, that you understand that they feel embarrassed about their situation, but you're here for them, you're going to help them through it. And then assist patient to identify their personal strengths and acknowledge their limitations, again, to kind of reinforce that positive body image about themselves. And then here's my 3 questions. So a knowledge check. What was the cause of the stress incontinence? You guys remember?
Coughing, pregnancies.
Coughing's right. I guess, yeah, you could probably have it with pregnancies with the increase in intra-abdominal pressure. I mean, it wasn't one I listed, but yeah, I'm sure that works also. And then when using Sudafed to treat incontinence, what were the 2 conditions that needed to use this medication with caution?
I know BP.
Right. Yep. And then there was one more. So it was BPH and hypertension. And then what type of treatment is the first choice of treatment for patients with urinary incontinence?
Is that like where they do retraining before?
Right, like the behavioral. Okay. Correct. So then here's my answers. And there's my references.
Nice job. That was good. I like your pictures. They're cute.
Thanks. A little corny, but
hey, that's all right.
That's okay.
It looked good.
Does anybody have questions on?
So I gave you this because, you know, we're getting ready to talk about renal stuff here next. And I don't really spend a whole lot of time talking about incontinence, so I figured this might be a good way to like have a refresher on it. Because I know you guys kind of talk about it in fundamentals, but you know, sometimes people forget certain things about it. All right, someone ask her a question.
Was there any treatments besides the Kegel exercises and the medications? Was there any like surgical procedures or anything like that?
Did you say physical procedures?
For surgical.
Yeah, I went over surgical procedures. I'll have to pull it back up to kind of list them again.
Okay.
Hold on. So the surgical procedures, that was the periurethral bulking where they add the collagen to the urethra, and that just adds like that extra pressure so that it can like close better. Then there's like anterior vaginal repair, retropubic suspension, which all help like to reposition the urethra in women with stress incontinence. And then there's artificial urinary sphincter, which kind of is a cuff that kind of mechanically like inflates and like helps you control your urine.
How that works.
I found a picture and it was actually really interesting, but I honestly didn't go like too in depth with it. I can pull it back up and show the screen. It's actually kind of weird looking.
I just wonder if the patient has control over that or how that works.
Yeah,
You know?
I don't know. Let's see. Let me look.
It's okay if you don't know. I'm just curious. I've never heard of that stuff.
Okay, let me share my screen. Okay, can you see my screen?
Not yet.
Oh, there.
There it is. Okay.
So, who's running your show? I guess it doesn't really. I can look to see if it says if you can control it, but it's kind of weird. Like I've never seen anything like it either. Like if you see this picture on the corner, like it is internal. Like it has like a cuff here around the urethra, and it also goes into the bladder.
Oh.
It's very weird. And then see, it looks like it's actually like in the testy, like the actual, like where I don't know where it's controlled.
Okay. Well, if you read about it and you figure it out, let me know. I'm just wondering.
Okay, yeah. I thought it was interesting too, but I guess I should have went a little further into it.
No, you're fine. All right, good job. Thank you for sharing all of that.
Thank you.
Okay.
Good job, Maggie.
All right.
Thank you, Brandy.
All right, so now we get to talk about thyroid problems. I can find my right page here. Okay, so anyone here in the class have hypo or hyperthyroidism? Or do you know anyone that has it?
There's several patients at my nursing home that have it.
Yeah.
They get Synthroids in the morning.
My friend has it.
Your friend has it?
Mm-hmm.
Okay, I was just curious because sometimes occasionally you'll catch a couple people who have had it before or currently have it. All right, so when we're talking about the thyroid is that butterfly-shaped organ that's in your neck here. So it's a gland in front of your neck that makes thyroid hormones. And so I don't know if maybe you should write this down. So there's certain hormones that it makes. There's 3 of them. There's one called thyroxine, which is T4. There's another one that I'm just going to spell because I can't say it. TRIODOTHYRONINE. This is T3. And then the third one is thyrocalcitonin or calcitonin. So again, the 3 hormones, T3, T4, calcitonin. That's what your thyroid makes, those hormones. So the secretion of these hormones is regulated by this negative feedback loop. So when T3 and T4 levels are decreased, then you have your TSH, which is your thyroid stimulating hormone, that's released by the anterior pituitary gland. So this is going to stimulate the thyroid to secrete more T3 and T4. So you kind of need that TSH to make the thyroid do what you want it to do. So calcitonin inhibits mobilization of calcium from the bones, and it decreases blood calcium levels. So dietary intake of protein and iodine is necessary for the production of thyroid hormones. So when we're talking about the thyroid then, whether we're talking about hyper or hypothyroidism, we're think about metabolism. We're talking about your metabolism. So with hyper, this means we're making too much thyroid hormones. And so our metabolism is kind of out of control. It's working overtime. When we talk about hypo, our metabolism is not working good enough. It's working very deficiently because we don't have enough thyroid hormones and everything is like a lot slower and not working as well. So with hyper then, which is what we're going to talk about first, our body's making too much T3 and T4, and this causes our metabolism to speed up. So we're essentially in a hypermetabolic state. Let me see if I can find, yeah, let me share this real quick. So if we were in class, so I'd be handing you guys these handouts so you had them in front of you. So I'm just going to show you real quick. So this top picture is this hyperthyroidism. So again, I said our metabolism is working overtime. It's working too hard. So with some of the signs and symptoms that you would see in someone like this, so typically when you have a really good metabolism, you have not a whole lot of weight on you. You're usually pretty skinny, right? So you might see weight loss in this because their metabolism is working overtime. Some of the other things that are kind of weird with this, tachycardia would be one thing. So our heart's working overtime. It's working really fast because it's part of our metabolism. Our blood pressure might be up. We might have tremors associated with this. We might have diarrhea associated with this. Because again, think everything's kind of speeding up and working overtime, right? Sometimes they'll get facial flushing. And then they have an intolerance to heat. This means that they're hot all the time, no matter what they do. So you see in this picture, this person's having this fan right in their face to try and cool themselves off, but even with that, they're still super hot. They're sweating, right? So intolerance to heat. There's a couple other kind of weird ones where I don't always remember these other ones. Like it talks about your hair, like you have fine straight hair with this. And like maybe you have menstrual changes like amenorrhea, but I mean that's not something I would expect you to remember. We'll come back to that when we talk about hypo, but that's that one. Okay. So anyway, you kind of get the idea of what signs and symptoms are of that, so I won't go through that again. But now I'm going to tell you about some of the causes. So the most common cause of hyperthyroidism is Graves' disease. So Graves' disease is a disorder where your body makes an antibody called thyroid-stimulating immunoglobulin that causes the thyroid gland to make thyroid hormones. Graves' disease runs in families and is more commonly found in women. So with Graves' disease, it's an autoimmune kind of a thing, so it leads to hyperthyroidism. Again, that's your most common cause. And there's a couple of specific things that you would see associated with this. One of those things is those bug eyes. I know that sounds stupid for me to say that, but they have a specific term for it. I can't say it, Exphtalmos, exophthalmos. So your eyes seem like they're like bugging out of your head. So this is due to edema in your extraocular muscles and increased fatty tissue behind the eyes. And then there's another thing that's kind of like a sign and symptom associated with Graves in particular, which is pretibial myxedema. So this is a dry, waxy swelling on the front surfaces of the lower legs. Okay, some other causes that you might see for this. Some people actually get this when they're pregnant, or after, first year after giving birth, they might end up with this. So, pregnancy would be another cause. Another one would be toxic nodular or multinodular goiters. So these are lumps or nodules in your thyroid gland that cause the thyroid to produce excessive amounts of hormones. And so I don't know if you've ever noticed, like when you go to the doctor for your checkup and your doctor will be like, putting their hand right here and like feeling for your thyroid, and they tell you to swallow. Well, they're feeling your thyroid to see if they feel any lumps or bumps there, because that's what they're looking for. They're trying to see if you have a nodular goiter there. Also, again, with some of these causes, another thing that I have on here is some people who consume too much iodine, like either from foods or supplements, or take medications containing iodine, can cause a thyroid gland to overproduce the hormones as well. So to diagnose this, typically they are going to do a physical exam on you. Like I said, they're going to like feel your thyroid there. They're going to do blood tests, and they're going to measure your TSH level and all the levels of your thyroid hormones, your T3 and T4, possibly the calcitonin, but typically just T3 and T4. And then if they think there's something there after they see some of those results, then maybe they might send you for an ultrasound or a nuclear medicine scan to look further, to see something a little bit closer. All right, and then as far as the testing goes, sorry, I'm just trying to find my spot here. All right, as far as the testing goes, they're going to draw that T3 and T4, and one or both of these must be high for them to say, yes, you have hyperthyroidism. They also probably are going to check your TSH level, and that'll show you something as well. If they think they want to, they might do an there's an iodine thyroid scan, and this will show this actually shows like how your thyroid gland takes up iodine. So you can kind of figure out if someone has hyperthyroidism from that as well. All right, so with this particular disorder, they have to be on some thyroid medication. So there's anti-thyroid meds that you can take. I'm going to mention two in particular that I want you to make sure you know. There's one called propylthiouracil, which is PTU. And then the second one is methimazole, which is Tapazole. Both of these two meds work by blocking the thyroid gland's ability to make new thyroid hormone. So typically in about 20 to 30% of patients with Graves' disease, treatment with drugs for the first 12 to 18 months will result in a prolonged remission of the disease. So that might be all they do, is just put you on these drugs. If you have this and you have it because you have that toxic nodular or multinodular goiter, maybe they might give you these drugs for a short time, but typically they're going to want to take your thyroid out, and so they're probably going to do surgery.
So,
yes.
I'm sorry, could you go back a second? You said it. What does it block?
So what they do is they block the thyroid gland's ability to make new thyroid hormone. So they would block the thyroid gland's ability to make T3 and T4.
Okay, thank you.
Mm-hmm. All right, so those two meds that I told you about. So there's some kind of minor side effects that go along with Tapazole. You could get like rash and hives and fever and joint pains from that one. It is the preferred drug, though, due to less side effects compared to that PTU, because the PTU can actually cause liver problems. However, like if you're pregnant and you find out that you have this and they want to put you on one of these drugs, the PTU is what they will put you on at first, and then they may switch you to something else later on in your pregnancy, which is weird, you know, but that's what they do. Okay, what else here? Couple other things they could do for treatment. There's something called radioactive iodine, and this is something that you could give people by capsule, and once it's swallowed, the iodine gets into your bloodstream and it's taken up by your overactive thyroid cells. And this destroys the cells that have taken it up, and it results in the thyroid or thyroid nodules shrinking in size. So there's a whole section in your ATI book about this on page 508. I would encourage you to read that because it's kind of interesting. When you are doing this radioactive iodine treatment, you need to be away from other people in your family because you're radioactive and you can cause other people to be sick. So you have to be kind of isolated from everyone else. You can't use the same toilet as everyone else. So you may have to have like a bedside commode. You can't wash your clothes with everyone else's clothes. You have to wash it separately and then run the washer afterwards, like another cycle to kind of get all of that out of there. You have to use plastic silverware. You can't use the regular, I mean, it's crazy. So they do this for a certain period of time. So obviously you wouldn't be on this for the rest of your life or anything. But generally, from what I understand, it sounds like they do this to make those nodules shrink up so they're easier to remove in surgery. So like you might do this in preparation for that.
Is that something that you could be allergic to and not be able to receive?
Possibly, yeah.
What would you do if you were? Just go straight for the surgery and hope for the best?
Yeah. So if they couldn't give that to you for some reason, you know, maybe they would try one of those other drugs that we were talking about. They could do something like that and see if that would help. And then, you know, if they thought they needed to take it out, they're going to take it out regardless.
Okay, thank you.
Mm-hmm. Okay, so the other thing that they can do for treatment is surgery. So the surgery would be a thyroidectomy. So again, you know, sometimes they'll have you take certain medicine to try and help shrink everything up so it's easier to remove. So like, I think in your ATI book, it mentions something called Lugol's solution as well. And Lugol's solution is, what it does is it's extra iodine that reduces the blood supply to the thyroid gland and makes the surgery easier and safer. And then also they said, you know, that those other two drugs that I originally mentioned, the PTU and methimazole, sometimes you'll see people take those for a little bit before their surgery as well. All right, so for the surgery itself, when someone goes in for this, typically the incision is pretty small. It's probably like about this size. So it's in your neck, and typically, you know, if you say I went in today for the surgery, I'd probably come home the very next day. But I'm going to tell you a little bit of specifics that I want you to kind of keep in mind about thyroidectomy, because you may have questions on this. So after the surgery, you want to make sure that you keep this patient in a semi-Fowler's position. So if you see any questions on a test that say anything about someone had a thyroidectomy and they're supine, that's a wrong thing to do. They always need to be up a little bit. You want to avoid neck extension. So like say you have to transfer this patient down to radiology or something, you want to like totally cradle their head and their neck as you're moving them over so that you don't have accidentally extended their neck, because you can cause problems. Other things that we're going to be worried about after surgery. So they're at risk for certain things. One of those is a messed up calcium level, like a low calcium. So we are going to be checking for Chopsticks and Trousseau's signs. Do you guys remember those?
I know one is like with your hand where you like hyperextend their arm or something, and if their hand starts shaking.
So you're thinking of Trousseau's sign, but that's when you pump up the blood pressure cuff and you leave it pumped up for like 5-10 minutes. And then after that period of time, if their hand like does this, then that's saying you have a positive sign.
Okay.
The Chopsticks is the one where you're tapping on their face in that certain area, and it causes their lip to like curl up funny.
Okay.
Okay. So you might be checking those signs after the surgery to see if maybe you see anything unusual. Other things that we're going to be concerned about, possible hemorrhage. So after surgery, you're going to be looking at this dressing, and obviously we don't want to see like a ton of drainage there. It's not uncommon to see a little bit, but if there's a ton, that's a problem. So you need to say something. So you should expect only a scant amount of drainage after 2 hours. The other thing that we're worried about is damage to the nerves that control the vocal cords. So it's not uncommon for them to have questions about like, oh, you need to have your patient talking to you a lot after surgery, because you want to hear their voice. You want to hear that they're not hoarse, because that's showing you that their vocal cords aren't affected. So if this person did have a problem with their calcium level after surgery, what could be some other signs and symptoms that you might see happening? If you have a low calcium, what might you see?
Fusion.
That's not quite what I'm looking for. What about like numbness and tingling? So like if you have a question that says, oh, they have numbness and tingling around their mouth or something weird like that, that's low calcium every time. So kind of review those signs and symptoms of low calcium, because those would be things you'd be looking for specifically after the surgery. Okay, so after they would take the thyroid out, this person is now considered hypothyroid for the rest of their life. So this means that they have to be on Synthroid or some form of Synthroid for the rest of their life every day. So that's something that the patient needs to be made aware of. All right, one more thing I want to talk about with this, and then we'll go on to hypo, I think. Yeah. Okay, so there is a complication that you can have when you have hyperthyroidism that you could go into something called thyroid storm, which I don't have a slide about this, so you need to just write things down. So thyroid storm is a sudden surge of large amounts of thyroid hormones into the bloodstream. So this is going to cause an increase in your body metabolism, and it's a medical emergency. So it's to the extreme. So we already know what hyperthyroidism is like, because we were just talking about it, and typically that's not a medical emergency. But in this case it is, because it's a sudden surge of all these hormones into the bloodstream, and now it causes like crazy symptoms that are worse. So things that you might see would be like hyperthermia. So their temperature is going to go way up. You're going to see hypertension, where their blood pressure is going to go way up. You could see delirium. You could see dysrhythmias on the heart monitor, like their heart rate could go really fast. You might see chest pain, palpitations, shortness of breath. So, you know how we were just talking about thyroidectomy, where you take someone's thyroid out? Well, that could be a reason why you would get this sudden surge of hormones into the bloodstream. It could happen just from getting your thyroid out. Other causes would be infection. Maybe you have an infection that caused you to do this. Trauma, DKA could cause this. Digitoxicity could cause this. And Graves' disease could cause this. So what you need to know then for treatment for thyroid storm is you're just treating the symptoms. That's all you're doing. So if I have a super high temperature, I'm going to do, cooling blankets. I'm going to put ice bags on them. I'm going to give them Tylenol. If they are doing all these crazy things on the heart monitor, I am going to probably give medicines for these weird heart rhythms that they're doing. I'm probably going to give them IV fluids and oxygen. I want to protect their airway, so if there's a worry about that, then maybe we intubate, And then during all of this, we are going to give an anti-thyroid medicine, right? Because that's the problem here. We have too much thyroid hormones that are squirting into our bloodstream. So the anti-thyroid med that we would give would be either that PTU or Tapazole. And usually that's going to be in IV form. So you give it quickly. Because remember, we said this is a medical emergency. Okay, so just to recap for a second, hyperthyroidism has to do with your thyroid gland right here in your neck, butterfly-shaped thyroid gland, right? The thyroid gland produces thyroid hormones. We said there's 3 of those. So T3, T4, and calcitonin. So it releases those. And then when you have hyperthyroidism, it means that you have too much of those released. And so it causes you to be in a hypermetabolic state. And so some of your signs and symptoms that you see are usually things that everything speeds up like. So high heart rates, high blood pressure, diarrhea, tremors, all these weird, things like that. You would also see intolerance to heat, stuff like that. So how do we diagnose this? We would do a physical exam. We would draw blood work to look at those levels, and then possibly send them for a thyroid scan that has to do with, what am I trying to say? It's in nuclear medicine. You send them to that, and they would be able to look at how iodine is uptaked into their system, and that would help decide if they have this. Other things, when we're looking at labs, if someone has hyperthyroidism, they're going to have increased levels of T3 and T4 and decreased levels of TSH. And that would indicate that they have this. Remember, we said we want to know causes of different things too. So number one cause of hyperthyroidism is what?
The thyroidectomy?
No.
Graves' disease.
Graves' disease, yes.
Right. Sorry.
That's okay. So Graves' disease is our number one cause. And remember I said there's a couple of weird symptoms that you see associated with Graves' disease. What are those?
Bulging eyes.
Yes. And what's the other one?
Some waxy parts of the lower legs.
Yes.
Front lower legs.
Yes, pretibial myxedema. And then also, I didn't say it, but goiters. You know, when people have a swelling right there of their neck, that's a goiter. So that would be another thing that you would probably see associated with that. Other things we said that could possibly cause this, if you have nodules on your thyroid, so nodules, toxic nodular goiter, that would be a cause. And then sometimes pregnancy, people can get it during pregnancy. All right, and then we said for treatment, there's different things we can do. We can try medications, which PTU and methimazole are those two meds that we talked about originally. And then occasionally, like depending on what your cause of it is, they're going to treat you slightly different, right? So if they think that your thyroid needs to come out, maybe they might give you something to help shrink up those nodules or something. One of those things we talked about was radioactive iodine. So remember, that's the one that you have to isolate yourself from other people because you're actually radioactive until you stop taking that for a while. And then the other thing we talked about was surgery, so thyroidectomy. So remember we said you always have to be upright after that surgery, so semi-Fowler's position. Support their head and neck really well. You don't want to hyperextend their neck. We're worried about low calcium. We're worried about bleeding. And we're worried about their vocal cords afterwards. Those are the three big things. What medicine would we give to someone if they had low calcium? Everyone should be saying something right now. What's that?
Is it calcitonin?
No.
Or like calcium supplements?
Yeah, so if someone has IV calcium, that's what we're going to give them, IV calcium after this, because, hey, they just had a thyroidectomy and they have a low calcium level. So just giving them PO isn't going to be enough usually. You want to shoot it up a little quicker. So you're going to give them IV calcium. Okay. All right, so is that clear as mud so far, or you feel somewhat okay with hyperthyroid?
Clear as mud.
You have to go over it a number of times to try and get it in your head better. It's, you know, when you first listen to it, it's like, oh my gosh. But then after you look at it some more, it starts to make more sense, I think. Plus, don't forget, I don't know if you guys even do Picmonic, but Picmonic has a lot of stuff in it. And sometimes something like that might make it a little simpler for you to listen to. And it's like nice short little things. So don't forget about that because they have a lot of stuff from this in there. Okay, so then, you know, the last thing we talked about was that thyroid storm. And remember, that's something that can happen if that's a medical emergency. And it's something where your thyroid hormones would just squirt into your bloodstream suddenly, and it causes like an exaggeration of all your symptoms to the extreme. And so you just treat the symptoms. Okay, so hypo. So hypo is going to mean that we don't have enough thyroid hormone that's secreted now. So your body's not making enough T3 and T4, and it causes your metabolism to slow down. So something that's kind of significant about hypo is that symptoms are often similar to what you would see when the aging process starts. So sometimes, like, a lot of older people might have this and it gets undiagnosed because you think that some of their symptoms are more related to their aging. So you'll see that happen quite a bit with this. Let's go back to that picture for a second. Okay, so now we're on this picture. So with hypo, like I said, you're going to have a slow metabolism now. So before, we had a low weight with hyper because our metabolism is working in overdrive and it's making you lose weight. So now, because our metabolism is so slow, you can gain weight from this one. So you might see that. With this one, you have an intolerance to cold. So you always feel cold no matter what you do. So like you see this poor guy has earmuffs and scarf and all this stuff on because he's so cold. Other things that you might see. So this talks about slow speech, anorexia. So you don't have much of an appetite. You're not eating very much. Look at the hair and nails now. So brittle nails and hair, whereas before you had nice hair and it was nice and straight and whatever. Constipation with this one because everything is a lot slower. So you're not having diarrhea, you're having constipation. You may have muscle aches or weakness, lethargy, bradycardia. You can have, what else? Cardiac things can happen. Like you can have some cardiac arrhythmias that happen with this. And then this even says subnormal temperature even. So there's a lot of things that everything just kind of slows down. Oh, let's see. We talked about, oh, one other thing, for signs and symptoms in here, it talks about you can have depression associated with this and sometimes impaired memory. I actually had a student of mine, an old student, who had this, and sometimes it takes them a while to diagnose this. Like they're thinking maybe it's other things and they try to rule all those things out and then they finally come up with this diagnosis. So she felt like everything was just kind of cloudy and foggy in her head all of the time, no matter what she did. And so then after she finally got on her Synthroid, after so many weeks, she felt like a new woman. She said it was like a light switch turned on, everything was clearer, everything was so much better. So I hear that from a lot of people, that it really makes a huge difference. Let me skip over some of this stuff. In some of these slides, like I have stuff that can happen if you don't treat it. And like it can happen in children and teens even. It's not always just older adults. And it can affect your development and everything. So you guys can read through all of that. But as far as causes, let's talk about that a minute. So probably your number one cause of hypo is going to be Hashimoto's thyroiditis. So this is an autoimmune thyroiditis, and it's a form of thyroid inflammation that's caused by the patient's own immune system. So, basically your thyroid cells are damaged and that's why they're not producing enough. That's kind of what's going on there. Another cause, maybe you have this because you had some kind of medical treatment that you were undergoing and that made you have to have your thyroid out, So if you had your thyroid removed surgically, you were hypothyroid. So that could be a cause. Other things might be you know, maybe there's a problem with your pituitary gland and it's just, you know, causing you problems with this. There's like a few different things, but the main one I want you to really remember is that Hashimoto's thyroiditis. That's usually the number one thing. All right, so when we diagnose this, again, they're going to do a physical exam. They're going to draw your blood. With this, if you have low thyroid, you'll have a decreased T3 and T4, and you'll have an increased TSH. And again, they may send you for that thyroid scan, and they're going to watch for the uptake of iodine in your system to see if you have it or not. For low thyroid, for hypothyroid, for that scan, it would be positive if they have a decreased uptake of iodine. All right, and then for treatment for this. So we have to be on some type of Synthroid or levothyroid or whatever. There's a few different names for this medication. This is an oral medication that restores your hormone levels and it reduces the signs and symptoms of hypothyroidism. Typically, when you start on this, it takes probably like 3 or 4 weeks before it really gets into your system and starts working well. On here it says usually you won't see like relief from some of your symptoms for a few weeks. This treatment is lifelong, so they have to be on this for the rest of their life, but the dosage needs to be checked every so often. So every time they go to the doctor, they're probably going to do a thyroid level to see where they're at. And if, you know, if your thyroid level is too low, then they might need to go up on your medicine. Or if it's too high, they might need to cut back. So as far as interventions go with this, again, we want to teach them about taking this, you know, every day like they're supposed to. And we want to monitor their vital signs and tell them to increase their fluids and fiber intake, because this person's already having constipation issues and that might help with that. They want to be on a low calorie, low fat diet because now they're gaining weight, you know, so you would want to have them on that type of diet. And then you want to tell them not to switch brands of their medication, because sometimes, like if you go to generic or something, your body's really sensitive to thyroid medicines, and so you need to have follow-up lab work. If you're going to switch to something, you need to be monitored. So that has to be checked out. So you need to make sure people understand that. Typically when they put you on this, they're going to put you on a low dose and then like kind of titrate you up to where they want you to be. So, you know, that might be something else that you would have to be concerned about. And then just like with hyperthyroidism, you know how we talked about thyroid storm? Well, there is an extreme with hypo as well, and that's called myxedema coma. So I want you to write that down, myxedema coma. So this is when hypothyroidism is untreated or when a stressor affects a client with hypothyroidism. Like say you get an acute illness, it might put you into this. Or maybe you had surgery and then maybe that'll put you into this. Or maybe you had chemotherapy or something and that, you know, causes you to go into this. I don't know. So with signs and symptoms of this, again, everything is to the extreme. So you remember your metabolism is really slow, so now it's even slower. So some of the things you might see would be respiratory failure, hypotension, hypothermia, bradycardia, dysrhythmias, hyponatremia, hypoglycemia, and coma. So again, just like with the other one, you're just going to treat symptoms. So we want to maintain their airway, maybe put them on a ventilator if they need it, give IV thyroid replacement, so they have to have Synthroid, and then also give glucose if they have a low blood sugar, give, you know, fluids if they need it, maybe do corticosteroids if they need it for some reason. So that's kind of how you would treat that. So again, myxedema coma is just something that is to the extreme where all of their metabolism is like super slow all of a sudden. Okay, you guys still with me?
Yeah.
Do you need me to recap what we just talked about, or you feel okay?
I mean, I think it'll take like 10 times for it to sit in.
Yeah, it does. Let me just try and recap quickly, and then we'll go to another presentation real quick. So again, hypothyroid is just low metabolism. So you don't have enough thyroid hormones working in your favor to help you with all of your metabolism, with all of the things that your body does. So with this, you're going to have all of these really slow signs and symptoms. So you may have a low heart rate, a low blood pressure. You can have problems with your weight where your weight would increase. You have intolerance to cold, where you're cold all of the time, no matter what you do. Constipation, those types of things. So to diagnose this, your doctor would draw your labs, maybe send you for that iodine uptake test. So that just is going to show if you have this or not. So that's kind of the things they would do for that. You have to be on thyroid medication for the rest of your life, usually some type of Synthroid or levothyroid or something. That doesn't work right away when you first start taking it, so it takes a few weeks to really start kicking in. You have to have your levels drawn every so often when you're on that, so that you make sure you're on a good dose and it's working and doing what it's supposed to do. And then remember we said myxedema coma is something that you could happen to the extreme with this. So this would be if your hypothyroidism wasn't treated, like maybe you didn't know you had it and you went into this, and that's how you figured out you had it. Or maybe you just got really sick, you were in the hospital with coronavirus or something, and then you ended up with this. So it could be any type of stressor like that, surgery or whatever. And so your symptoms are just very extreme, like you could go into respiratory failure, all this stuff. So you just treat the symptoms, and that's kind of what helps with this. Okay. Who else wants to go for their presentation?
I will.
Okay. So you guys, while she's getting ready to go here, I know you don't want to sit here forever and listen to all this. I get it. But, we only have so much time to go over things, so I apologize. I'm trying to get through it the best I can with you. Now, after we go over this, you need to refresh your memory about this stuff. So whether you do it right after class or you do it later on this evening or something, give yourself a break and then come back to it. But you need to refresh your memory on these things so it doesn't get out of your head and you can kind of start getting it, because there's a lot here. Oh, hey, Maggie, can you send me your presentation in email?
Yeah, I can do that.
Yeah, Ashley, you too. Anyone who goes today, just send me a copy of that in email.
Okay.
Okay.
All right. I don't know if I'm going to say this right. It's systole?
Cystocele.
Cystocele. Okay.
Yeah.
All right. I don't even know how to work this thing. There we go. Okay. The pathophysiology. There's 3 factors. Can you hear me all right?
Yeah.
Okay. I'm getting like weird noises on my end. Okay. 3 factors that support the position of the uterus and vagina. The one is the ligaments and fascia. This does this by suspending from the pelvic side walls. The second is the levator ani muscles. They constrict and maintain the position of the organs. And the third is the posterior elation of the vagina. It's enhanced by the rises in the intra-abdominal pressure that causes closure of the flap valve. What is systole?
Cystocele.
Cystocele. Why do I keep saying it like that?
That's okay.
What is this? It's also referred to as a vaginal or bladder prolapse. The vaginas are supported by levator ani muscles and connected tissues. I can move this. Attached to the side wall of the vagina and the pelvis. The vagina normally lies horizontally on the top of the levator ani muscles. This is so weird. Okay. When damaged, the levator ani muscles lay vertically. The vaginal opening widens and shifts the support to the connective tissues. The risk factors. Vaginal bursts. This is because it strains the muscles of the pelvic floor. Family history, obesity, intense physical activities like heavy lifting is that too. A hysterectomy, constipation, because the repeated straining messes up your muscles. Coughing, drop in estrogen. The estrogen keeps the muscles of the vagina strong. So when you don't have that, you lose all that. And menopause. There's 4 stages. There's stage 0, and that is no prolapse. Now, I was pondering what pictures, because I went with these, but I really wanted to go with the real life ones. Because if someone would see, like when I saw it, it would be hard to distinguish if you were looking at a male or female.
It definitely changes you for life. I've seen these in real life, and I'm forever haunted.
Because I was like, what? I had to make sure it was a female. So these pictures don't do it any justice. It's terrible. So the stage 1, it is, how do I explain this? The distension just starts coming out of the vaginal opening, just a little bit. It's not even out yet. It's just starting down the canal. The stage 2, it's closer to the level of the hymen. And then the stage 3, it's down there. And then the stage 4, it's out. So if you want to think of like a bladder or anything, it's hanging out of the vagina opening. So it's very, I never saw one until the other day when I was doing this, and it's very eye-opening and crazy. Signs and symptoms. They can feel like a bulge in the vagina, feeling of heaviness or fullness in the pelvic region, aching or pressure in the lower abdomen and pelvis, lower back pain, frequent urinary tract infections, leakage of urine, the need to void urgently, incomplete emptying of the bladder, constipation, painful during intercourse, and pelvic pressure.
Can you imagine even trying to have intercourse with that? What the heck?
I don't
Honey, can you move your prolapse? Thanks.
I put that in there. I'm like, oh my gosh, I don't even know how you, I don't know. Okay. Pelvic pressure that gets worse through the day when standing, lifting, or coughing. The diagnosing is they can do a complete medical history and physical, but this is not a definite way because sometimes doing a physical, it's not at a stage that you can feel or see yet. So if a doctor's trying to look up there, he's not going to find anything. I wouldn't say the most common, but the biggest one would be the voiding I'm going to butcher this.
Cystourethrogram.
Okay. They do this by placing a catheter through their urethra into the bladder. It will fill the bladder with contrast dye, and it takes like pictures while the patient is voiding. So if you can imagine having, I don't even know, just having all of these pictures, it was neat. And then, but that's kind of more invasive. So the MRI is the one that's the most non-invasive. But the problem with the MRI is the patient is in a supine position. When the patient's in a supine position, then it takes the pressure off of the bladder coming out. So then they might not get all the right pictures and what they need. The benefits to this is that there's no catheters used. There's no dye or radiation that can be harmful to the patient. And the MRI, it will provide very clear details of the 3 pelvic compartments, which the voiding cystourethrogram, I don't know how to say that. It doesn't show all that. So MRI is like the more, probably for an older person too. So they don't have to go through all that trauma if they already have issues. Treatments are pelvic floor muscle training, exercises like Kegels that help the contraction of the levator ani muscles to help improve symptoms associated with stress, urinary incontinence. This approach is used more for women who have mild prolapse. Okay, I'm gonna move this is so weird having moving the screen constantly. How do I get rid of the whole, there we go. So this is the other treatment. It's a reconstructive surgery that is made by, the decision is made by the surgeon and the patient based on the patient's expectations and their goals. This could be based on their cultural views, religion, body image. The patient's bladder will be put back where it belongs, in the wall between your bladder and vagina, in the wall between the bladder and the vagina. So this would not happen again. So it's a picture. This is where they're cutting, and then this is like step by step. I wish I would have, I didn't know how you would react to a real like picture. So I went with this one. But it's very, like it's out, and then they're sewing just weird. And this is the, catheter. Another treatment is a pessary. They're devices that are placed in the vagina to restore the normal pelvic anatomy, and this decreases the prolapse symptoms. This is an option for all the stages, and this might also prevent or delay the need for surgery. So if you did have stage 1 or stage 2 and it's not that bad yet, then they could place a pessary in, and how it just goes in, it's inserted into the vagina. And then this little loop, can you see my mouse?
Yeah.
Okay. These little loops, they like, this picture doesn't show, but I researched that. It goes around, how it fits in there, it's like if you were looking at 3D, and so those little holes line up and attach in there so it stays. And there's different ones. There's the ones with the holes, and then there's this one for depending on what grade or stage you're at. The nursing diagnoses I picked was the urinary retention related to the bladder sagging or moved out of original place, as evidenced by small frequent voiding or absence of urine output. The second diagnosis was the body image disturbed, related to the defects as evidenced by actual change in appearance, structure, and function of the vagina, as evidenced by low self-esteem with the body presentation. So I thought that was a big one, because if you were at an age where you had some kind of life like that, how would you even feel? I don't think, that would be a big problem with somebody. Depression and all that would tie in. And the last one was sexual dysfunction related to altered body function or structure as evidenced by vaginal fullness and pressure. Well, like I mentioned before, you're not going to want to, that life is pretty much over. If you have something coming out, you can't, it's impossible. If anybody was wondering what it looks like, go look it up. It is very eye-opening. And Brandon, I don't know how you saw it in real life, but
I think I shared the story, but I had a patient told me she needed to sit down on it to push it back into place. And it was at Sumo when I worked there, and she would stand up, and she's like, okay, you need to push me down on the corner of the bedside commode so it can go back in.
Oh my gosh.
I don't know. I've heard stories of people saying their whole intestines fell out. Then I had to do this. I'm like, that's what happened. Their intestines weren't hanging out. Okay. The nursing interventions are for the urinary retention, I chose to instruct the patient and their significant other to observe the different signs and symptoms of urinary tract infection, like chills, fever, frequent urination, or concentrated urine, and back pain. Also teach the patient to achieve an upright position on the toilet if possible, so it's easier to void. For the body image interventions, I chose recognizing the normalcy of response to the actual or perceived change in body structure or function, and support verbalization of positive or negative feelings about the actual or perceived loss. The sexual dysfunction was the encouraged discussion of the factors related to
cystocele,
and teach the patient to verbalize acceptance of the disease, encourage positive talk about the disease process, and focus on the outcomes rather than focusing on all the negatives. Okay. What is the treatment called that helps with the pelvic floor strengthening?
Kegels?
Yes.
Sweet.
What is the most non-invasive test to diagnose systole that requires no catheter use or radiation?
Is that the MRI?
Yes. Can women that never had children get diagnosed with
cystocele?
So do you guys think that women that have never had children can get this also?
Yes.
Yep. Here's the answers. Yes, you don't have to have kids to get this. It can happen to anybody. And here are my references.
Great, something to look forward to, right?
Right. It's pretty scary. It frightened me. I'll tell you that.
Well,
I'm like, man.
You know, there's other ones too. It's not just cystocele. There's rectocele too.
No, I saw all those.
Yeah, there's a lot. So,
yeah.
Yeah, I picked this because we don't really talk about it a whole lot in class. So I just wanted people to be aware of it because you know, it's definitely something you could see in the future, and you need to know what the heck it is and what's done for it. A lot of older women who have this do that pessary, those things that they stick up there to try and keep it in place. I had someone who had one of those, and her pessary kept falling out, and then she would be like, oh, here, hold on, let me put that back in. And she, you know, it's crazy. And I was like, what the heck is this thing? And here it was their pessary. I'm like, oh my gosh.
It would be scary. I know that. It was
Good
weird.
job, Ashley.
Thank you. It was weird because my mother-in-law had said just like last week that she knew some lady, and I didn't even know. I was not last week, the week before, that her whole intestines came out, and I was like,
jeez,
it wasn't her intestines, obviously.
Yeah, she just didn't know any better.
Right.
Right. Anyone have a question?
Do you know like what's the average age this would usually start at, like the stages?
The average age I came across was like a menopausal age. So I don't want to say 40, but around probably 40 to 50, depending on, you know, when you're going to go into menopause. But there was young people too, because it's caused by, it can happen to anybody. And then the heavy lifting, anything can mess up those muscles.
Right.
So no, I didn't have an average age.
Okay.
But it's pretty much the estrogen loss. So that would be the menopause. And then, you know, the other factors. But
Right. Okay, cool. Thank you.
You're welcome. Are you worried about it, Brandy?
I
am now.
Hey, right. Now that I've seen it and you, I'm like, great. I fit into all those categories of childbearing and age and all that stuff.
Yeah. Me too. I'm right there with you.
You're doing your Kegels.
I know. I'm doing some right now. All right. Thank you, Ashley. That was good. All right. If you can stop sharing your screen, we'll go back to the rest of this stuff. Good job. Okay, let's see here.
Professor Silk, are you able to retrieve ours online if we turned it in through the assignment tab?
Do I have an assignment tab for that?
Yeah, I turned it in there this morning.
Oh, okay. Yeah, then that's probably fine. I'll find it.
Because I can email it to you, but I'm not home. Like, I'm on Zoom on my phone, but I'm not home, like, next to my computer right now. Okay.
No, that's okay. Don't worry about it.
Okay.
All right, so the rest of this, we've got hyper and hypoparathyroidism we need to talk about. So with hyperparathyroidism, our parathyroid glands, we have 4 of those, and they're very tiny, and they're located right next to our thyroid gland. So I don't know if I have a good picture. Let me see. Yeah, I have one here in a second, so I'll show you here in a minute. But basically, with hyperparathyroidism, we have excessive secretion of parathyroid hormone. And the parathyroid gland is what secretes that. And it causes you to have hypercalcemia and hypophosphatemia. So think back to when we talked about all of that in Adult 1. Anytime you have high calcium, you have low phosphorus. Anytime you have low calcium, you have high phosphorus, right? So what's a normal calcium level, you guys?
Is it 8.5 to 10.5?
Yeah. And then what about phosphate?
That's a low one, isn't it? I'm trying to remember. I think it's low.
But it's 2.5 to 4.5. Okay. So just kind of keep those in mind as we're talking about this, and hopefully it'll make things make more sense. All right, so there's 2 different kinds of hyperparathyroidism. You can have primary and secondary. So primary is an enlargement of one or more of the glands, that causes this to happen. It causes you to produce too much of the hormone. And then secondary is going to be as a result of another disease. So like, I don't know, I'm trying to think of an example of another disease that could cause this. I don't know, maybe you had a tumor or something that was causing you to do this. You know, that could be like a secondary thing. So with your symptoms, so again, we said we have too much calcium and low phosphorus. So when you have too much calcium, you're going to be at risk for certain things, right? So you're going to be at risk for kidney stones, for one. Another thing would be bone fractures. So you'll have fragile bones. That will be part of your symptoms here. And it's funny, you would think, you know, producing lots of calcium that your bones would be really strong, but that's not the case. It makes it like less strong because it's just unstable. You'll be at risk for constipation, GI problems, frequent urination, and also EKG changes. Because I don't know if you remember back to when we talked about calcium in adult 1, we said that you can have some arrhythmias with that. There's something called short QT interval that you can have. I try to put a little bit of pathophys in a lot of these so you can kind of see what's happening. There we go. So anyway, this kind of explains what's happening with this. The parathyroid glands are supposed to maintain your levels of calcium in your body and your phosphorus. So it kind of is like if you can think of a switch on a wall, you know, like a light switch or something, it kind of works like that. It can turn on or turn off depending on what your body is doing, right? So normally, you know, this works really well, and your calcium levels in your body, you know, if they fall too low, it'll turn on, it'll secrete more, and, you know, there you go. But sometimes it gets out of control and you can get too much. So that's kind of what this is saying. All right, so with the different types, we already talked about primary and secondary, so I'm not going to go into that too much. But there's some complications we can have. So again, if you have too much calcium, you can have osteoporosis, so it's going to make you fracture a lot easier. You can have kidney stones. You can have cardiovascular disease. And then you can also have neonatal hypoparathyroidism. So this can happen in really little kids as well. So to diagnose this, they are going to do blood tests again. So they want to rule out other things because there's a lot of things that can cause high calcium levels. So they're going to rule out some of those things. One of the things they would be drawing would be your hyperparathyroidism level. You know, they're going to look at that. So they want to see how much parathyroid hormone you are making. They're also probably going to draw a calcium level and a phosphorus level just to confirm. Other things that they might do, they might send you for a bone density test or a urine test or an x-ray of the kidneys even to try and see, you know, what's going on here. As far as treatment goes, if your calcium level is only a teeny bit up, then they're not going to worry about it too much. Typically, they'll just kind of keep an eye on it until it starts to get up too much, you know. If your kidneys are functioning normally, you don't have kidney stones, your bone density is okay, they're just going to watch it. However, surgery is the most common treatment for this. So if you have this, it's going to provide a 95% cure of all cases here. So the surgeon would remove only those glands that are enlarged or have a tumor. So typically you have 4 of these things, right? And so they're tiny, almost like a grain of sand. They're that small. So if all 4 glands were affected, the surgeon would still only remove 3 of the 4 glands. So they would leave the 4th one there because you need to have a little bit of functioning parathyroid or you're going to be really messed up. So medications to treat this would include things like Sensipar, hormone replacement therapy, and biphosphonates. So hormone replacement therapy would be like estrogen, you know, and then the biphosphonates, that would be like your Fosamax. It would be stuff like that. There also, I just want to say a little bit about that surgery. So if you did a parathyroidectomy, this is very similar to what we talked about with thyroidectomy. You're going to watch for the same things. So you're going to be concerned about their respiratory status afterwards because, yes, your incision's going to be right here, just like it was for the thyroidectomy. So you're always going to be worried about swelling in their airway, right? So again, semi-Fowler's position at all times. You're going to have a trach kit at the bedside just in case you would need it. Same thing with the thyroidectomy, which I forgot to mention that earlier. You would also want suctioning equipment right there. You're going to also watch for low calcium levels and that laryngeal nerve damage, like we talked about with the thyroidectomy. So you're worried about them talking. You want to hear their voice, so you know they're not going to be hoarse there. So same types of things. So just remember that it's very similar. Okay, so then with hypoparathyroidism, so now we're not producing enough parathyroid hormone. So now we are going to have not enough calcium and too much phosphorus. So it's going to be opposite. So here's some of the things that you might see as signs and symptoms. You could have tingling or burning in your fingertips, toes, or lips, muscle aches, twitching or spasms of your muscles, patchy hair loss, painful menstruation, fatigue or weakness. You know, there's a ton of weird symptoms. But more, I would kind of concentrate more on the muscle aches and twitching and that type of thing than anything. With causes, this could be like an autoimmune type of a thing, like in some of those other disorders we talked about. It could be that you just inherited this. It's a hereditary thing. It could be because you had a parathyroidectomy before, so you've had some parathyroid glands out, so now you're hypoparathyroid. Maybe you've had extensive cancer radiation treatment to your face or neck. That could have caused it. Or low levels of magnesium in your blood. All right, complications would be, tetany, paresthesias, loss of consciousness, convulsions, you name it. And then some irreversible complications. You could even get stunted growth, slow mental development in children, calcium deposits in the brain, which can cause balance problems, seizures, and cataracts. So lots of crazy stuff. Again, when we diagnose this, we are going to draw levels. So we'll probably draw a calcium level, a phosphorus level, parathyroid hormone level, maybe even a magnesium level to see where we're at with all of that. And then treatment, we are going to treat this with calcium. So we're going to give oral calcium carbonate tablets. We'll probably give vitamin D along with that. And then there is a medicine called NatPara, which is parathyroid hormone. So if they're low in that, we're giving that NatPara, and that's, treating that. And then you want to eat a diet that's rich in calcium and low in phosphorus. So you would be talking to people about that. So again, thyroid and parathyroid, very similar, right? So your parathyroid glands control your calcium. So if you don't make enough, you're going to be low in calcium. So you're going to treat that by giving calcium and vitamin D, right? If you make too much of it, you can have things like kidney stones and osteoporosis related fractures, all that kind of stuff. Okay. All right, I'm going to go through one more thing real quick before I give another person to do a presentation, because I don't want us to get too far off here. Okay, how many of you have heard of pheochromocytoma?
Never heard of it.
Nope.
Nope.
Oh, I should have did a poll. Let me see if I can try that. I'm just curious about this poll.
Just curious, what time do we let out today?
When we're done. So
Oh, okay.
I'm just trying to get through stuff.
I got you.
All right. So there's just a lot today. So we'll do the best we can. I know if you have to go, you have to go, you know. Okay, so pheochromocytoma. So this is, basically it's a tumor. It's going to be in your adrenal glands. And I don't know if you remember to the beginning of this, we showed that picture, and your adrenal glands are on top of your kidneys, right? And so that's where this would be. So a tumor there. Usually this type of tumor affects either one or both of those adrenal glands. And if you have this, it can cause you to have some crazy symptoms. Typically when people get this, they're between 20 and 50 years old, but it can develop at any age. So what we're worried about with this tumor is that it can cause you to have high blood pressure. That's our biggest concern here. With that, just like you would see anyone else who had a problem with high blood pressure, you can get like heavy sweating, headache, rapid heartbeat, tremors, shortness of breath, you know, that kind of stuff can go right along with this. So typically you feel kind of crappy when you're having this happen. Now, if you have this tumor, it doesn't mean that you're constantly having these symptoms. There are triggers that can trigger a spell where you would have this happen. So like you could do, you know, physical exertion, you could have some type of stress going on, maybe you did surgery, had surgery on something, you know, labor and delivery, even having foods high in tyramine. So stuff like that could cause you to trigger a episode where you're going to shoot up your blood pressure and have all those crazy symptoms. So researchers don't know what causes this, but it develops in certain cells called chromaffin cells. And if you looked at the adrenal gland, it's kind of like a triangle, and they have different parts to it. This tumor would be kind of right towards the middle. And so because it's right there, it affects your hormones in your adrenal glands. So our adrenal glands have our adrenaline and noradrenaline, so epinephrine, norepinephrine. And those help control our fight or flight symptoms, right? So that's why, you know, you can have the higher blood pressure, faster heart rate because of that. So it kind of makes more sense. So, of course, we don't want someone to sit there and live with having these episodes because they're going to be at risk for stroke or heart disease or kidney failure, you know, all these different things that can happen as a result of high blood pressure. So this is another important thing that maybe you should star in your notes. So to diagnose this, we are going to do a 24-hour urine. So this 24-hour urine and blood test, actually both, they are going to tell us if this person has this pheochromocytoma. And then if you see that that looks positive, then that would say, okay, yes, let's do some imaging now, you know, so then you maybe would send them for a CAT scan or an MRI. So the treatment for this is surgery. That's going to be your main thing. So they're going to go in and remove the tumor. But before you undergo surgery, you have to make sure that this person's blood pressure medications have things kind of under control. You want to block the actions of these hormones to lower the risk of developing a dangerously high blood pressure during surgery. So many times they'll put this person on alpha blockers or beta blockers beforehand so that when you take them to surgery, you won't have this issue. In some unusual situations, when there's another adrenal gland that has to be removed, surgery might remove only the tumor, sparing some of the healthy tissue. So, like, generally, they're probably just going to, you know, try and save as much of your adrenal gland as possible. Does that make sense? So I just want to tell you a teeny bit about the surgery. So if they did the surgery, this would be an adrenalectomy. So you could be having like a high or low catecholamine imbalance, because of this. So you need to watch this person in the first 24 to 48 hours really closely for problems with their blood pressure. So it could be maybe even very severely low even. So you need to watch that closely. They're also at risk for hemorrhage, so you're watching for bleeding. And then you're going to give corticosteroids, IV fluids, try to maintain a quiet environment, and also assess for hypoglycemia, because that could be a thing that you could see too. If both adrenals are removed, the client will require lifelong replacement of adrenal hormones. So then constantly for the rest of their life, they would have to take those. All right, so we literally have 2 more things to go over. So I'm going to see if you guys can do your presentations real quick, and I'll go over the rest of that here in a minute. So who wants to go next?
I will.
Okay. Ready to go?
Yeah, give me 1 second. I'm pulling it up.
All right, you guys be as quick as you can so we can get done with the rest of our stuff, because I know everyone wants to get off here.
Okay, so it's making me leave the meeting in order to share my screen for some reason. Hold on. Do this one more time. Share.
There we go.
Okay. All right. Let's do. Okay. So I had interstitial cystitis. Yes. What is interstitial cystitis? It is a feeling of pain and pressure in the area of the bladder, along with having lower urinary tract symptoms, which have lasted for more than 6 weeks with no infection or any other kind of causes, also known as painful bladder syndrome, and can be mistaken for an urinary tract infection. The cause of interstitial cystitis is not completely defined, but there are many hypotheses on what causes this disease. One of them is the epithelial dysfunction. The urothelial surface is lined by impermeable bladder surface mucin, composed of glycosaminoglycans, also known as GAGs, and glycoproteins. Any changes in this surface can cause permeability alterations, allowing potassium ions to cross the urothelium, depolarizing sensory and motor nerves, and activating mast cells. Antiproliferative factor has been recently found in people with interstitial cystitis, and it inhibits cell life and impairs repair of damage to the urothelium, this resulting in the changes of the barrier function of the urothelium. It has autoimmunity causes and has many factors of an autoimmune disease. It can be chronic, it has exacerbations, it has remissions, it responds to steroids and immunosuppressives, and it has, when you have it, you have a high number of antibodies. Cultures in patients are usually negative, and polymerase chains reactions have not continuously found bacterial genetic material. But an episode can cause dysfunction, which results in the alteration in bladder permeability, neurogenic upregulation, and mast cell activation and recruitment. So what that's basically saying is an infection could cause this to happen. Signs and symptoms. One of the signs is Hunner's ulcers. Those ulcers stiffen the tissue and cause reduced bladder capacity. Distinctive areas of inflammation on the bladder wall that characterizes the classic form of interstitial cystitis, but only about 5 to 10% of patients are seen with this form and usually have more severe symptoms. Other signs and symptoms is bladder pain, urinary urgency, frequent urination. The symptoms can change from day to day or remain constant. Discomfort while urinating and glomerations on the bladder wall. And then this is the glomerations of right here, the little pinpoints.
Is that the red spots?
Yeah, all these red spots right here.
Okay.
Risk factors is they're usually female. You can see them in male, but for some reason, it's more prominent in females. 40 and older, they have chronic pain disorders. They also usually have inflammatory autoimmune disorders like IBS, people with allergies and sensitive skin. To diagnose this, it's usually diagnosis of exclusion, meaning it's usually diagnosed after a number of other symptoms have been ruled out. A cystoscopy to look at the bladder wall of glomerations or Hunner's ulcers. But the thing is glomerations may be present on a normal bladder wall as well. Treatment. It's usually behavior changes to avoid anything that causes these flare-ups. Exercise, sexual activity, constipation, tight clothing, or high acid foods. They could be put on tricyclic antidepressants to relax the bladder and hinder the release of neurochemicals that cause bladder pain and inflammation. And Elavil is one of those. Pentosan polysulfate sodium helps repair defects in the bladder lining, but this can take several months to reduce pain and urinary frequency. They would also take NSAIDs and acetaminophen because that would help with the inflammation. Cyclosporine A is a immunosuppressant drug, helps relieve symptoms, but is limited to use because of serious side effects. Dimethyl sulfoxide helps relax bladder and alleviate pain. Weekly installations for 6 to 8 weeks, and then every 2 to 3 weeks for 3 months or more. They do use this, but they don't use that as much anymore. Also, heparin and lidocaine combine one or both of these drugs with Almiron and is administered to quickly reduce pain and inflammation and helps restore mucus in the bladder. Specialized physical therapy, working with a physical therapist trained in pelvic soft tissue manipulation and rehabilitation, may help release scars and other sources of pelvic pain. Avoid doing Kegels or any exercises that strengthen the pelvic floor muscles. They also would do InterStim, which it would stimulate the sacral nerve in the lower back and alleviate urinary urgency. What this does is it, when you have this disease, sometimes the neurons somehow get disconnected, I guess you could say, and the InterStim reconnects in, how did it say? It basically brings back the where you can control your urinary function. Nursing diagnosis, deficit knowledge related to foods that may exacerbate symptoms as evidenced by unchanged behaviors. Educate the patient on the importance of a lifestyle change and staying away from highly acidic foods. Acute pain related to inflammation of the bladder wall as evidenced by patient feeling pain in the lower back and perineal area. To help with this, encourage the patient to drink lots of fluid to dilute the acidity of the urine. The acidity would aggravate the bladder and causing it to inflame. Impaired urinary elimination related to incompetent bladder as evidenced by urgency. If the patient is going to the bathroom every 5 minutes, have them try to hold it for 60 minutes. This could help retrain the bladder and the efficiency with which the bladder empties. I'm sorry.
It's okay. You got this.
How is interstitial cystitis diagnosed? Anybody?
I'm thinking.
It's okay. Just keep going because
Is it after it's ruled out from other complications? Yeah, like once they rule out UTIs and all kind of other things, then they will go to this last.
Yeah. What is a Hunter's ulcer?
Oh, those are the lesions or the patches. You showed us the pictures, those dark red things. They're like you mentioned inflammation of the bladder or something like that.
Yeah, they're the there was a picture on there about them, but yeah, that's it. What percentage of people get Hunter's ulcers? Oops, sorry.
that's okay. We got to speed it up anyway, so that's okay. So 5 to 10%.
And then there are my references.
Perfect. So did you know that much about this before I gave this to you?
No, I didn't even know what it was.
Yeah, so see, that's kind of a good thing that we're doing these, so at least you learn something different, So thank you. That was a good job.
Good job, Nestle.
Thanks.
All right, please send that to me so I have that too. All right, and Olivia, were you the last one that has to go?
Yeah, I think so.
Okay, see if you can do yours real quick and then we'll finish up.
Okay. Let me
just read every other slide.
Yeah, don't feel like you have to read everything. Just try and give us the general points of stuff.
Okay, I was gonna say mine, I kind of summarized a lot of it on the slides too, so I don't think it should take.
Okay, perfect.
Can you see my screen yet? Or let me try.
So when you hover on the thing down below, you should see something that says share screen. It's green.
And then do I hit desktop?
So when you click that, you should see a bunch of different things that you might have open on your computer. Just find the one that you're wanting and just click on that.
Okay, I don't let me make sure. I think this, It's saying the same thing. Do you want to leave this meeting? I don't know why.
Neasley, what'd you do when yours said that?
It somehow just popped up. I put no, and then it just popped up somehow. I really don't know what happened.
That's weird because I have an option to share screen. It's in between chat and record.
Oh wait, I think this is it. Let me try it. Hopefully.
Yeah, there you go.
Okay.
You got it.
All right. Present. Okay, so my topic was, I don't know why Land's goal keeps popping up now, but my topic is benign prosthetic hyperplasia. Oh, why is it not letting me? Okay, well now it's not letting me.
If you hit return, will it go forward?
No, I'm hitting return, but yeah, it's not even, my screen's like locked on this.
All right, that's okay. Just see if you can start talking about stuff.
Can you manually just click? Oh, there you go.
There you go.
I don't know what I did, but okay, there we go. So what is benign prostatic hyperplasia? It is the non-cancerous growth of the prostate. It's the most common problem, prostate problem in men. It occurs when the cells of the prostate multiply and these additional cells swell, which squeezes the urethra and then limits the flow of urine. It is not the same as prostate cancer, and it does not increase the chances of getting it, but it can affect your quality of life. It is common in men over the age of 50, and it can be considered a normal part of aging. Okay, let's see how I went forward. I don't know.
Do you have arrows on your keyboard that you can just go forward with an arrow?
I'm trying that too, and yeah, it's locking me out. I don't know what oh wait, maybe this?
Yeah, try that.
Okay, slide 3. Okay, so the pathophysiology, it results in the enlargement of the prostate that restricts the urine from flowing from the bladder. It enlarges due to hormones, so a decrease in testosterone is thought to be the cause of BPH. Throughout their life, men produce large amounts of testosterone with small amounts of estrogen. As they age, testosterone decreases, which causes an impairment. And then the hormone DTH plays a role in the enlargement of the prostate. So the testosterone decreases, but DTH is still at high levels, which leads to the prostate cells to grow. I'm sorry, I'm like all over the place because I know everyone's trying to.
No, you're fine. Don't worry about it.
Okay, so risk factors. So age, as I said before, men over 50 have a higher chance of getting this. Gender, this only occurs in males. Family history, if you have a close relative, you have a higher chance of getting this. Obesity can increase the risk of getting this. A diet high in saturated fat, red meats, and refined sugars can make symptoms worse. And diabetes, heart disease, and beta blockers can also increase the risk. Okay, so some signs and symptoms are urgent need to urinate, urinating more at nighttime, difficulty starting urination, unable to completely empty the bladder, slow urine stream, and pain while urinating. And then put the less common signs and symptoms, which is a UTI, blood in the urine, and inability, not able to urinate at all. So let me. Okay, so a urine test can be done to diagnose or rule out any other infections. Digital rectal exam checks to see if the prostate is enlarged. A PSA blood test, these increase when the prostate is enlarged. A cystoscopy, a camera inspects the inside of the prostate and urethra channel and bladder. And post-void volume, this measures how much urine is left over. And a urine flowmetry measures how fast the urine flows. Right, and then treatment. So medications are alpha blockers. This relaxes the muscle of the prostate and bladder and helps improve urine flow. An example is Flomax. And then 5 alpha reductase inhibitors. block the production of DTH, which is that hormone that causes the enlargement, and then helps shrink the prostate and improve urine flow. And an example is Proscar. And then combination medications are just those two combined. If one's not working, they can combine them to improve symptoms. So some surgeries are prostatic urethral lift. This is done by needles, place small implants in the prostate, and this helps so the enlarged prostate doesn't block your urethra. And transurethral microwave thermotherapy uses microwaves to destroy the prostate. A device sends microwaves through a catheter to heat sections of the prostate, which I thought was interesting. I did not know that. Treatment continued. So transurethral incision of the prostate. This is done when there's a major blockage. Surgeon uses laser beam to make small cuts in the bladder neck or the prostate and urethra. I can't see that. I think urethra join, which will help decrease the pressure on the prostate and make urinating easier. And then the most common or very common surgery is the transurethral resection of the prostate. Surgeon uses wire to cut away any prostate tissue that is blocking, and the removed tissue is flushed out into the bladder where it leaves the body. And a patient will need a catheter 1 to 2 days after surgery. And then my nursing diagnosis, urinary retention related to enlarged prostate as evidenced by you're unable to empty bladder completely. Interventions encourage patient to void every couple of hours and when urge is noted to decrease bladder distension. And then administer medications. Fear and anxiety related to change in health status. And then encourage patient to express concerns and feelings and provide information about what it is and like any surgeries or medication they would be receiving. And then my last one is impaired urinary elimination related to bladder distended as evidenced by inability to completely empty the bladder. For this, you would assess the voiding pattern and palpate the bladder. All right. And then my questions are, what is BPH? I was gonna say I can keep going if you just want me to.
Can't believe no one's saying anything. Did everyone leave or something?
No, I just didn't. I don't want to be the only one talking, but
Just say it. Yeah.
It's the prostate gland enlargement.
Yeah. What is a common risk factor? I know there was I listed like a bunch of them.
Age, right?
Age.
Yes. Yep. And then what hormone plays a role in the enlargement of the prostate?
Oh, DHT. I'm not even going to try to say it.
Yeah. Oh, no, it's okay. That's why I'm saying it. And then there's my answers. And then here are the references. Sorry, guys. I was talking so fast. I just was trying to get through it for everyone.
No, you're fine. So is there stuff that you learned from this that you didn't know before?
Yeah, I've heard of it, but I didn't know really anything about it until I started researching it and reading in the book about it, everything.
Yeah, it's kind of interesting. And if you ever get to take care of someone like this, it's kind of really interesting too, because this is usually the type of patient who has that split catheter where they have irrigating and stuff coming out. There's like 3 ports to the catheter. Have you seen that before?
I think I've seen a picture of one before.
Yeah, this is typically where they use that, because after the surgery, this person typically will have like blood clots and stuff in their urine, so they constantly have that irrigation going through there to get those clots out, and so they'll do that for like the first couple of days.
Okay. Yeah, I've seen a picture of that before.
Yeah, it's pretty neat. All right, nice job. Thank you.
Good
All
job,
right.
Olivia.
Thank you.
Sorry you felt rushed. I know it's like we don't have enough time.
No,
to do
you're
anything.
fine. I felt like I was talking so fast. I was like, no one can understand me. I feel like I'm talking so fast right now.
No, you're fine. You did a good job. Okay, so this is the last of it, guys. We're going to talk about Addison's disease and Cushing's. Let's see, where the heck is everything? Okay, so Addison's disease. This is going to deal with the hormones. Actually, there's like 3 groups of hormones that this deals with. So we talk about mineralocorticoids, glucocorticoids, and sex hormones. So it's all 3 of those. So Addison's disease is where your body produces insufficient amounts of these hormones. And these are the hormones that are produced by our adrenal glands. Remember, those are right by the kidneys there. So with the mineralocorticoids, this is where we talk about aldosterone. Aldosterone increases sodium absorption and causes potassium excretion in the kidney. So aldosterone is a mineralocorticoid. When we talk about glucocorticoids, this is your cortisol. So cortisol affects glucose, protein, and fat metabolism, the body's response to stress, and the body's immune function. So again, cortisol is a glucocorticoid. And then the sex hormones that we talk about would be androgens and estrogens. So in Addison's disease, your adrenal glands produce too little cortisol and often insufficient levels of aldosterone. So both of those top 2, the mineralocorticoids and glucocorticoids, those 2 things would be affected with this. So you're not producing enough. All right, let me keep going here. So let me show you that picture that has to do with this. This would be this lady. Okay, so what I want you to kind of think about when you're thinking signs and symptoms with Addison's, I want you to remember the bronze pigmentation of the skin, because that's significant and different compared to anything else you might see. Another thing I want you to focus in on would be hypoglycemia, postural hypotension, and then look down in that little box where it talks about adrenal crisis. So it talks about a low sodium and a high potassium. Those are kind of the things I want you to focus on the most. So the change in the skin, the low blood sugar, the low sodium, and the high potassium, low blood pressure. Those are the big ones. So I get that I'm going over this kind of quick and it's going to go in one ear and out the other. I get it. But you have to make sure that you look at this stuff a little bit closer, because there's a lot of different hormones that are involved with this particular disease. And if you understand what these hormones do, it makes more sense of what's going on because you're deficient in those. All right, so if you remember, President Kennedy, John F. Kennedy, had Addison's disease. And if you would look at pictures of him, he had that bronze pigmentation of his skin. And I looked up articles about him, and it talked about during his presidency, they tried to keep things under wraps so people wouldn't realize that he had this. But there were times where he would be like giving a speech somewhere, and all of a sudden he would pass out. And that would be his low blood pressure, sometimes low blood sugar from this. And then he also would have other things that he would suffer from. So like a lot of these symptoms he had. So it makes sense when you really think about it. Some of the causes of Addison's disease would be maybe your adrenal glands are damaged for some reason. So they're not producing enough of the hormone because they're damaged. You could have, I'm trying to find it, darn it. Maybe it's on this. Some of the hormones that the cortex produces are essential for life, like the glucocorticoids and mineralocorticoids that we were talking about. So that cortex part of the adrenal gland, which is like towards the middle. So if you are not having enough of some of those, that's what gives you your symptoms. And this kind of explains that a little bit more. So there is a primary and a secondary adrenal insufficiency. So primary, this is when that cortex part of the adrenal gland is damaged. And so then your adrenal glands just don't produce enough because of that. So down towards the bottom here, it talks about other causes, like maybe sometimes people get infections of different things like tuberculosis or something else more significant, and that could cause that problem. Cancer, you know, bleeding to the adrenal glands, any of those things could cause you to have this. Secondary adrenal insufficiency is can occur if your pituitary gland is diseased. So now it's the pituitary gland. So this gland makes a hormone called adrenocorticotropic hormone, ACTH. So this stimulates the adrenal cortex to produce hormones, and this can lead to insufficient production of those hormones produced by the adrenal gland. So the one is, hey, my pituitary, not my pituitary, but my adrenal gland is messed up, and that's why I'm not producing enough of these hormones. Secondary is, hey, it's my pituitary gland up in my head that is not causing me to not produce enough hormones to, you know, make my adrenal glands work right. So that's kind of what that is. There is an extreme with this one as well. So remember, our extreme things that we talked about so far had to do with thyroid, right? So thyroid storm with hyperthyroid, myxedema coma with low thyroid, and now Addisonian crisis with low hormone levels of, you know, mineralocorticoids and glucocorticoids. So for this one, if you have this, it's because maybe you have untreated Addison's disease, you just don't realize you have it. This can be provoked by physical stress, such as an injury, infection, or illness. So like, maybe I don't know I have this and I'm out in the population and all of a sudden I get a bad case of the flu or something, and that causes me to go into this. So this would make you go into acute adrenal failure, and you would get things like pain in your lower back, severe vomiting and diarrhea, low blood pressure, loss of consciousness, really high potassiums, low sodiums, like, you know, just to the extreme. So again, treatment would be just treating those symptoms. So you're usually going to give IV injections of hydrocortisone, saline solution, and sugar, because we're trying to treat all of the problems specifically that they're having. So the hydrocortisone would be to treat their problem with their hormones that they're having. The saline solution would be to treat the sodium issue, and then the sugar would be to treat the low blood sugar. Okay? To diagnose this, they're going to draw blood levels. So they're going to look at your sodium, your potassium, your cortisol, and your ACTH. There is a test called an ACTH stimulation test, and it involves measuring the level of cortisol in your blood before and after an injection of a synthetic form of it. And I have done this before, and you guys probably will in your practice as well eventually. So they actually send this up from pharmacy, and so you have to do like a blood level before, and then you give the med, and then you have to do a blood level after to see the reaction. There's also an insulin-induced hypoglycemia test that you could do where, you know, maybe there's a problem with the pituitary and that's what you're thinking, like it's a secondary adrenal insufficiency, so they could do that. And then there's also imaging tests that they would do to look at your adrenal glands to see what's going on. So with treatment, this is kind of important. So anyway, with treatment, you have to do this hormone replacement therapy for like every day for the rest of your life. So this person's on oral corticosteroids. So hydrocortisone or prednisone or something like that to replace their cortisol. They also may be on fludrocortisone to replace their aldosterone, you know, depending on if they have a problem with that too. There are corticosteroid injections that sometimes people will get, and this is if you are really sick and you can't take your medicines for some reason, maybe you need to go into the hospital and then they will do that for you until you get better. So an ample amount of sodium is recommended during times where you're doing heavy exercise or it's really hot out, or if you have sickness like a GI upset. Your doctor will suggest a temporary increase in your dosage if you're facing a stressful situation. So like if you have, a sickness or you're going to do a surgery or something, you're going to have to increase your dose. So you're actually taking sodium pills. So this person not only is taking a corticosteroid like hydrocortisone, but they're probably also taking fludrocortisone, to help with the aldosterone problem that they're having. And then they also have to take sodium pills. So they're taking all of that. And this is kind of unusual because they can up their dose of sodium if they have to, depending on what they have going on. So they don't have to call their doctor and say, oh, can I take more of this? They have specific orders from their doctor on what to do with that. Okay, and then Cushing's. So Cushing's is now we have too much of those hormones we were just talking about. So you remember glucocorticoids and mineralocorticoids? Now we have too much of all of that. So Cushing's syndrome occurs when your body is exposed to high levels of cortisol for a long time. It's also called hypercortisolism. And then too much cortisol can produce some of these signs that we're going to look at here. So you'll have certain things that you'll be like, oh, that's Cushing's, just when you see that. So actually, I'll just show you these. I won't pull up that other picture. But so with common signs and symptoms, so this is going to be your person who may have really skinny arms and legs, they're really tiny, but then they're big around the middle. So they have an apple or pear shape to them. So common signs of Cushing's would be they're going to be overweight, so they'll be big around the middle, lots of fatty deposits and things around their middle, right? Then they're going to have what you call a moon face. So their face is going to be shaped kind of differently. So it's going to look more fuller-like. The other thing they're going to have is a hump between their shoulders of their back. So this is called a buffalo hump. What else? Okay, they also could have stretch marks on their skin, from being big. They could have thinning, fragile skin that bruises easily. You could see slow healing of cuts or sores. They may have lots of acne or have a flushing to their cheeks. Other things that you might see, you could have, I can't say it, hirsutism, which is visibly more facial hair or body hair, in places where you wouldn't want to see it on a woman, or irregular or absent menstrual periods. And then with men, they could see a decreased libido, a decreased fertility, or erectile dysfunction. And so these things would be more as a result of those sex hormones that we talked about, if they had an issue with those, if too much of that was being produced. Okay, so causes for Cushing's. So you can have excess levels of cortisol. Geez, I don't have. Here, let's go here. Here we go. So this can develop from a cause outside of your body, like exogenous. So one example is taking oral corticosteroid medications for too long of a period of time, like huge doses for a real long period of time. Another thing could be endogenous things. So maybe you have a pituitary gland tumor, or you have a primary adrenal gland disease, or maybe it's just familial Cushing's syndrome that you have. So it could be one of those things. So complications that you can have from this, one of the things would be bone loss or osteoporosis. So again, they have these real tiny little arms and legs, and so their bones can break really easily. So anytime you see questions about Cushing's, a lot of times they'll talk about be real careful with how you move this person because you could break their bones real easily. So they could have, you know, unexpected fractures and stuff. They're going to look unhealthy because they're overweight. So they're going to have high blood pressure. They're going to have diabetes. They're going to be at high risk for infections, stuff like that. That's what you need to be thinking about with this person. So they're unhealthy looking. To diagnose this, it's kind of difficult to diagnose, but they can do urine and blood tests to measure your hormone levels to see, you know, if you have too much of all of that. There is some kind of saliva test, I guess, that they can do with this. Of course, you could do imaging scans to look at those areas where those glands are. And then there's something called petrosal sinus sampling. So you actually can go up this person's nose with these, like, this, I don't even know what to call it, this thing that can get like a piece of their gland to test and make sure that's what it is. And then for treatment of this, of course, you're going to treat some of the symptoms that they're having, right? So you are going to try to reduce corticosteroid use if you can. So if you are someone who has to be on it daily, then maybe you could talk to your doctor about reducing your dose or maybe trying something different. That might be good. Surgery, they could do surgery if they had to. Radiation therapy, you know, if you have a tumor, then maybe that's how they're going to treat it. Just kind of depends on the cause. And then medications would be to control the excessive production of those hormones. So you might take something like ketoconazole or mitotane, any of those drugs I have listed there. Those would be things that would help you know, cut down the production of those hormones. Okay, so that's that stuff. I apologize, it's a long day, I know. It's just a lot of information, so I just wanted to make sure I got it to you so you have it at least. So as you were starting to look over this stuff, and I probably will do another review session with you guys like we did last time. We'll try to do that again. So maybe Monday or Tuesday, I'll come out with something for you guys. But anyway, as you're looking over this, you know, reread stuff. You can look in your ATI book. You can look in your other book, wherever you need to go. Look at it again. Watch some videos. You can go to that registered nurse RN. She's got a ton of practice questions about this stuff. So that's kind of helpful, I think, to do some practice questions. And then, you know, as you're looking through your notes, maybe you just rewrite your notes in different ways to see if that helps you keep things straight. You want to keep straight what hormone you're talking about, what it does, where it comes from, those kinds of things. Because you can get confused really easily in this stuff. Does that make sense, you guys?
Yes.
Yeah.
Yeah.
All right, so if you have any questions, you can get a hold of me. I'm sorry, this is a long day. It's not a good way to go over this stuff. All right.
Thank you.
You guys have a good rest of the day,
All
okay?
right, have a good one.
Thanks. Bye.
You too. Thanks.
You too.